that right now. And we're a little past 11, and I know maybe we should begin with our introductions, and people will join us in process. I'll share the general program with people's presentation titles and bios of speakers and our session chairs once again, in case anybody in our audience wants to look through those at any point. So those are in the chat. And I think we could begin. And so I'd like to kind of formally, if you will, say good morning to everyone from New Jersey, and good evening to all of you joining us from Greece. Καλημέρα σε όλους και όλες από το New Jersey και από την Ελλάδα. We'll continue, as I said earlier, in our event in conversation in English, but we encourage anyone in the audience who may prefer to speak or share comments or ask a question in Greek to please do so by using the chat, or feel free to raise your hand and ask a question later on when we get to that point of the event. We are thrilled to welcome you to this joint eSymposium, the first that Rutgers University and Democritus University are co-hosting in the context of a broader array of activities we have begun working on together. Although, as Chancellor Strom from Rutgers will explain in a few minutes, Rutgers and Democritus are not strangers to each other. Our institutional partnership has been renewed and strengthened through our participation in the International Academic Partnership Program, Greece. IAPP Greece is an academic incubator program sponsored in 2020 by the Greek Ministry of Education, the U.S. Department of Education, the Institute of International Education, and other organizations, including the Fulbright Foundation, and designed to promote international collaboration between U.S. and Greek institutions of higher education. I'm Matthew Matsiganis. I'm an associate professor at Rutgers University School of Communication and Information, and the co-lead of the Rutgers IAPP Greece initiative. Bit of a back of my research focuses generally on the role of communication as a determinant of health inequities and other kinds of inequities in urban environments, in urban communities. But I'm also interested in the work on how the well-being of neighborhoods can be transformed through communication-centered interventions. My co-lead in this effort is Professor Reba Tugger-Decker, who you'll see in one of our Hollywood windows here on Zoom. She's also the Associate Dean of Global Affairs at Rutgers School of Health Professions. And the third member of our organizing committee is our colleague from Democritus University of Thrace, Dr. Christos Kontogiorgis, who will also be sharing some of his research with you later on. At this point, we want to acknowledge and thank the leadership of our Rutgers schools, our deans, Jonathan Potter of Sky and Gwen Mahone of the School of Health Profession, as well as our associate deans of academic programs and research, and of course our chair of the department, including Leah Stewart, who is here with us today. Our initiative's overarching objective in the IAPP has been to advance health communication, research, education, and practice across the health professions, both in Greece and the US. Today's event brings together experts from across Rutgers and Democritus University to address a tremendously pressing public health issue in both the US and Greece: substance use, and specifically use of opioid-based and other psychoactive drugs. It is a public health issue that affects the lives of thousands of individuals and families in both these countries. Our speakers' presentations will speak to the severity of the issue, but we'll also go deeper and talk about substance use patterns, advanced and underlying mechanisms, treatment, and policy interventions. Through the event, we hope to advance dialogue between experts on both sides of the Atlantic that could support the development of solutions, or better solutions, to substance use problems. At this point, before we go on to our speakers and their work, I want to also pass the mic over to Democritus University's Vice Rector of Academic Affairs and Student Welfare, Professor Zoe Gavrilidou, who would like to welcome you from Greece. We'll also hear briefly from Dr. Brian Strom, the inaugural Chancellor of Rutgers Biomedical and Life Sciences and Rutgers Executive Vice President for Health Affairs, and from Professor Michael Koukourakis, the chair of the Department of Radiotherapy and Oncology at Democritus University School of Medicine. Professor Gavrilidou, the mic is yours.
Thank you very much, Matthew. Dear colleagues, ladies and gentlemen, it is a great pleasure to participate in this inspiring event, even for non-specialists like me. And I would like to congratulate the Laboratory of Hygiene and Environmental Protection of the Department of Medicine of Democritus University of Thrace and the Rutgers University on this thought-provoking initiative within the frame of the International Academic Partnership Program. For Democritus University of Thrace, the IAP program was a flexible and effective tool for partnership building, offering new possibilities. It also offered Democritus University of Thrace an empowering and in-depth understanding of the opportunities for strong academic collaboration, like the one which is presented today in this event. And I'm glad and proud that our university actively participated in it by establishing contact with important universities in the United States, like Rutgers University, Princeton University, or Columbia University. The subject of today's event, which focuses on substance use in Greece and the U.S.A., make us all reflect on the sound ethical decision-making, which is essential for the medical staff during clinical care in order to demonstrate ethical rigor. And of course, it sees a broader ethical debate in the academic literature. So I sincerely wish a very successful conference. Thank you.
Good morning, and thank you for inviting me to start today's conversation. Although I'm unable to join you in person at your virtual session, I'm pleased to have the opportunity to record this welcome so that I may share my excitement and support for this burgeoning collaboration. This conference is the first joint endeavor between the Democritus University of Thrace and Rutgers University, a relationship that has been facilitated by our joint institutions membership in the International Academic Partnership Program of Greece. I am, of course, already familiar with the Democritus University of Thrace and the work being led by its excellent faculty within the pharmacoepidemiology field. I've made multiple trips to visit, and I even had the great pleasure of being awarded an honorary doctorate from the university in 2018. It's wonderful to greet my friends from Greece, at least virtually, and see this relationship continue to mature. Though much has changed over these past 4 years, sadly, drug abuse, specifically the abuse of opioid-based and other psychoactive drugs, remains one of the most pressing public health issues in both the United States and Greece. According to the National Institute on Drug Abuse, opioid addiction claims the lives of more than 2,500 New Jerseyans and 45,000 Americans every year. Rutgers researchers, including some of whom are here today, have worked for several years to address this devastating crisis, as have our colleagues and public health stakeholders in Greece. Today's eSymposium convenes these experts from across our institutions to share the lessons learned from their research and service within their respected communities. There has never been a more appropriate time to join forces and tackle one of the most pressing public health issues faced across the globe. The pandemic has amplified healthcare disparities within our communities and undeniably elevated the critical importance of health research, outreach, and collaboration. By focusing on advancing health communication research, education, and practice across the health professions in Greece and in the United States, this collaboration between our institutions critically incorporates health sciences, health professions, and health communication. A unique and interdisciplinary undertaking at our university, the Rutgers Academic Partnership Program in Greece notably bridges our institution's organizational branches, as it is co-led by the Rutgers School of Communication and Information and the Rutgers School of Health Professions, with support from Rutgers Global. The conversations today are an excellent way to launch such a collaboration between Rutgers and Democritus University of Thrace, and demonstrates our joint commitment to engage globally to encourage a more culturally intelligent and globally mobile health sector workforce. That's why I'm grateful to Professors Riva Tower-Decker and Matthew Matsaganis for their work in co-leading this effort on behalf of Rutgers. I look forward to engaging further with my friends and colleagues across Rutgers and the Democritus University of Thrace as this partnership flourishes, and look forward to being able to go back to visit Greece again as the pandemic burns itself out. So once again, welcome, and thank you for participating in this trailblazing initiative.
Excellent. So I pass the virtual mic over to Professor Koukoudakis. You're muted.
Excuse me. Yes, common mistakes. Dear colleagues, on behalf of the Medical School of the Democritus University of Thrace, I welcome you in the current important scientific event organized by the Laboratory of Hygiene and Environmental Protection of our university and the Department of Global Affairs, School of Health Professions of the Rutgers University of U.S. In the pre-Socratic Greek philosophy, what is best is hidden from man, and what mankind can do is to try to find the aminon, the better, as the best is kept only for the gods. Science and medicine are struggling to find better and more efficient ways to serve our beloved fellow men. The networks between distant centers of knowledge, the universities, certainly accelerate and strengthen our march to uncover what is better. Drug abuse is among the most appalling phases of diseases, as it is deeply rooted in the necessity of man to escape the darkness of the unsatisfactory world we are called to live in. The dreams promised by the initially comforting altered reality offered by drugs hide within them the nightmare of a monster that will eventually haunt the dreams and the real life of the man who has desperately tried to find comfort in the imaginary life created by the drugs. I congratulate Professor Kondogiorgis, Professor Konstantinidis, and all components of the Laboratory of Hygiene of our university on their initiative to organize the current scientific event in collaboration with the Rutgers University. Through their long-lasting collaboration, they contribute greatly to the establishment of our medical school as a major research and educational center in Greece. I wish you every success in this endeavor to uncover the better ways to help our fellow men and eradicate the plague of drug abuse from our planet.
Thank you, Professor Koukoudakis, and I guess we're ready to go into our first session. So I'll leave it to Professor Tiger Decker and Alexiou Hadzaki to take us to the next session, to our first session.
Thank you. Thank you, Matthew, and thank you everyone for your incredible introductions and meaningful statements about the problem we're battling today. Good morning and welcome to the first half of our first joint eSymposium between Rutgers and Democritus University. I'm Riva Tiger-Decker, the Associate Dean of Global Affairs and a professor at the School of Health Professions and the Rutgers School of Dental Medicine. As Matthew said, I'm his co-lead on the IIE-IAPP Greece program, and Matthew will be chairing the second half of our session. Today's program will be presented in two parts. During the first part of the program, we'll hear from 3 speakers, each for about 15 to 18 minutes. Each presenter will share their screen during the presentation to show their slides. I'm going to be keeping time, and I'll be giving the presenters 3-minute and 1-minute warnings. I think, as Matthew said, we're recording the session and it will be posted up on our website. After the first 3 sessions, we'll be going on a brief 10-minute break. Then we'll commence with part 2. However, if you have a burning question and the speakers are willing to address them, we can do a Q&A period during the break for those who don't want to break. At the end of the second half, we'll open the session to a broader Q&A from everybody about all the topics. If you're uncomfortable speaking your question, feel free to submit it in the Zoom chat, either in English or in Greek. But when you do ask your question, either verbally in writing, it would be very helpful if you would state your name and your organizational affiliation. Towards the end of the last session and during the Q&A period, a link to a brief anonymous evaluation tool will be posted in the chat. We'd really love you to take the few minutes to respond because your feedback will help us with future program planning. If you'd like a certificate of participation for today's session, please follow the link that will be posted in the chat, and one will be emailed to you separately. I will introduce our first two distinguished speakers from Rutgers this morning, and then Dr. Hatsaki will introduce our third speaker from Democritus. First, we have Dr. Mita Ray, who will be addressing the neurocognitive mechanisms underlying opioid addiction. Dr. Ray is an associate professor in our School of Health Professions. Her research aims to examine the cognitive, behavioral, and brain mechanisms that are underlying drug addiction in this vulnerable population, including pregnant and new mothers in the community, and to develop new and effective interventions to improve the health outcomes of these individuals. She has over 15 years of experience working in drug addiction. She will be followed by Dr. Petros Livonis, who will address the pharmacological treatments for opioid use disorder. He is a professor and chair of the Department of Psychiatry at the Rutgers, New Jersey Medical School. He is also the new president-elect of the American Psychiatric Association. Dr. Livonis served as the director of the Addiction Institute of New York from 2002 to 2013 and is an honorary member of the World Psychiatric Association. He has published 14 books, including the textbook Substance Dependence and Co-occurring Psychiatric Disorders, a pocket guide to LGBTQ mental health, underlying the spectrum of gender and sexuality, and technological addictions. So without further ado, I'll invite Dr. Mita Ray to please share her screen and her slides and get started. Dr. Ray, I will give you a 3-minute and then a 1-minute warning.
Thank you, Dr. Targa Decker. I'm so excited to be a part of this symposium, and hi to all of my colleagues, those who are in the Greece and those who are in the United States. So today I'm going to talk about the work I have been doing on opioid addiction for the past 3 to 4 years. In 2019, the National Institute on Drug Abuse declared that the U.S.A. is going through an opioid overdose crisis. Opioids, mainly synthetic opioids, are currently the main driver of drug overdose deaths. Approximately 72.9% of opioid-related overdose deaths involve synthetic opioids. Here are the data published by the Center for Disease Control and Prevention, CDC Wonder database, released in December 2021, is showing us the national drug-involved overdose deaths from 1999 to 2020 on multiple drugs. What we can see here that this is the line for synthetic opioids, primarily fentanyl. And we see that in 2020, close to 60,000 people died from fentanyl overdose. Compared to this, we have prescription opioid and heroin here, little less than 20,000. So these numbers are incredible. So now I'm going to talk about the research goals that I have. Number one is to understand the effects of long-term opioid use on a large-scale brain network using structural and functional MRI measures and experimental tasks. And number two is to develop interventions that will target this brain network in individuals with opioid use disorder. Mainly, I'm interested in this particular brain network called drug cue processing network. It involves the mesocortical limbic and nigrostriatal systems in the brain, and that are implicated in drug reward craving and relapse. So this particular network includes 10 brain regions, and I have outlined them here. Some of them are subcortical regions, for example, ventral striatum, dorsal striatum, amygdala, hippocampus, and some of the brain regions are cortical brain regions like anterior cingulate cortex, prefrontal cortex, and so on. Actually, this network was developed by my colleagues and I in 2015 when we are working in the context of cocaine addiction. And this network is mainly dopaminergic in nature. So we all know dopamine is a chemical messenger which is naturally produced in the brain that affects higher order thinking, attention, memory, and reward systems. Addictive drugs, including opioids, cocaine, increase dopamine in our brain and hijacks the reward system that leads to a maladaptive addiction pathway. So as a result, the individuals get no satisfaction through natural reward. So take an example of an opioid user who before the addiction used to enjoy a hamburger. But after the addiction develops, the person doesn't get any satisfaction from eating hamburger. Only thing this person wants to take is the drug. So I'm going to talk about experiment 1, wherein we are going to examine the structural and functional brain differences between OUDs and healthy controls. Again, I am interested in the drug cue processing network, or DCPN. We first scan their brain structures and we analyze the brain volumes. Then we scan the brain function. We are interested in measuring resting state functional connectivity. Our hypothesis was individuals with opioid use disorder will show structural and functional abnormality within DCPN, as opioid addiction is characterized by brain reward dysregulation. 26 individuals with opioid use disorder and 20 healthy volunteers took part in this study. We utilized a 3T Siemens Trio scanner to scan our participants. We first scan their brain structure and then we scan their brain function. These are some of the parameters we use to scan their brain. So just to give you a brief overview on MRI and fMRI, in MRI, we take one image of the brain, which is a very high resolution image of the brain, whereas in fMRI, we take many images of brain every 2 seconds. It's kind of taking a video of the brain. So for example, an opioid user is looking at a bag of heroin. So certain areas in the brain will get activated. That means the neurons in those brain areas are going to get activated. As a result, there will be an increased blood flow in those brain areas and blood oxygen level will go up, and that will increase the fMRI signal. So in fMRI, what we are measuring is called blood oxygen level dependent, otherwise BOLD signal, and which is an indirect measure of neural activity. So this is our setup in the Rutgers University Brain Imaging Center in Newark. So here is our console room, and you can see the magnet in the separate room. We have a glass window here. So we operate the scanner through this computer, and we can see there is one participant inside the scanner, and we can see that a sagittal view of that participant's brain. So these are the results of the brain structural analysis. So these are the subcortical regions in the brain: striatum, hippocampus, amygdala, nucleus accumbens. The blue bars are from the opioid users and the red bars are from the controls. The results showed that individuals with opioid use disorder showed significantly lower brain volume in multiple subcortical brain areas. However, we did not see any differences in terms of brain volume between the groups in cortical areas, for example, insula, prefrontal cortex, and so on. During the resting state scan, participants actually looked at a crosshair inside the scanner for 8 minutes. They were instructed just to keep their eyes open and not to move. So this is an example for of one brain slice here, and we are scanning this particular brain size over the time. And for example, these are the 2 brain areas. So this is the line, which is the BOLD signal emitted from this particular brain area. And this blue line is the BOLD signal emitted from this brain area. So you can see that those 2 BOLD signals, they are kind of overlapping. They are highly correlated. So we can say that these 2 brain areas are functionally connected. Resting state functional connectivity was computed in terms of Pearson R correlation between all region of interest pairs. So we have 10 brain regions. We created 45 pairs of brain regions from the 10 brain regions within DCPN for each participant. Next, we examine the difference in the resting state functional connectivity, Pearson's correlation R values across the two groups conducted for each ROI pair. So for example, we are measuring resting state connectivity between amygdala and hippocampus. So we'll emit bone signal here, we'll have the brain signal here, we'll measure the correlation between two brain signal for each of the individuals between the two groups. Then we'll conduct a 2-sample t-test to see whether the resting state connectivity is different between the two groups. The results showed that there was no differences between the groups in terms of resting state functional connectivity for any of the region of interest pair. So I wanted to bring out an important point here, that the kind of analysis we did, like univariate analysis, where we identified only one variable and used 2-sample t-test to see whether the groups are different. So for example, the volume for amygdala, the volume different across the two groups, or for resting state functional connectivity. So for this particular pair of brain regions, amygdala, hippocampus, is this connectivity different between the two groups? So it shows that with this kind of analysis, we could not find any differences between the two groups in the cortical brain areas, as well as in resting state functional connectivity analysis between the two groups. So in order to address that, we use something called multivariate machine learning classifier that can utilize all brain volumes at the same time, multiple variables. Instead of one brain at a time, we can give this classifier 10 brain regions volumes data, or resting state functional connectivity correlation values from all possible region of interest pairs at the same time. So what it does, the classifier actually utilizes algorithms that search for patterns among the features. That means among 10 brain regions. And that way it can separate participants into two groups, either in opioid or control. So they learn one pattern from the opioid users' data, and then learn another pattern from the control subjects' data. Then you give this classifier one new opioid user's brain data, and it is going to classify that new person either in the opioid or in the control group based on the patterns it has learned before. So using this analysis, we saw that structural MRI features reliably discriminated OUD from healthy subjects, as well as resting state functional connectivity features also reliably discriminated OUD from healthy subjects. So conclusions, chronic opioid use is associated with both structural and resting state functional connectivity abnormalities within drug processing network, which is a large-scale reward-related brain network. And these specific machine learning results support that the structural and functional features extracted from the drug processing network are disease relevant. So in the next experiment, I'm going to talk about a particular task we used, is called persistence task. So literature suggests that negative emotion is associated with substance craving and use in individuals recovering from substance use disorders, including opioid use disorder. So an individual who is recovering from the addiction, experiencing negative emotion is very common. They experience negative emotion and stress very frequently, and they do not know how to regulate that emotion. And as a result of the negative emotion, craving is triggered, which results in relapse. So examining this negative emotion is very important in this substance using population. Decisions to abandon or persist towards a goal after negative emotion eliciting events and neural responses that shape such decisions may be important in maintaining recovery from opioid use disorder. We examine differences in neural responses to negative events and subsequent persistent decisions in individuals recovering from OUD. These are the two hypotheses we tested. Number one, OUDs would show decreased persistence behavior. And number two, their brain responses to negative affective events would be different from the healthy controls. In all of this analysis, we are comparing opioid using individuals' performance with healthy controls. So 20 opioid users and 20 controls from experiment 1 took part in this study. We had the same inclusion-exclusion criteria as in experiment 1, and MRI structural data were collected as part of experiment 1. During this persistence after setback task, we measured their bold response. So here is an example. So participants had to choose one of the 3 paths, either path A, path B, or path C. And the end of each path, they get some points. Based on the total points they achieve in the experiment, they get a small bonus. So once they choose a path, they face with an obstacle. They had to press the correct key to avoid it. It can have 2 consequences. They can receive the setback, that means they go back to the beginning of the path, or they move forward in the path. So if they receive the setback, that means they are going back to the beginning of the path, they have to make a decision whether they want to continue on the same path or they want to change the path. So this is where we are measuring the persistence, which is the percentage of decisions to continue on the same path after received setback. Whereas on the other case, they move forward in the path, and then they again face an obstacle and they press the correct key to avoid it. So if they press the correct key, they move forward, otherwise they move back. We also analyze their bold data while they are receiving the setback between the 2 groups. These are the results. We found out that individuals with opioid use disorder were less persistent after setbacks. That means, suppose they're using this path and they get a setback, they tend to change their paths. Whereas the control subjects, they continued on the same path. So here is the big difference. I think this has important implication in terms of recovery. So
you have 3 minutes remaining.
Thank you. Individuals who are in the recovery and they have a setback, for example, the relapsed momentarily, they should continue their motivation to continue so that they stay focused in their path of recovery rather than stopping it and go back to their use. So it is a simple task which is going to tell us whether this person is motivated enough to reach their goal. In the left putamen, we saw that opioid users showed lower bold signal to negative events compared to controls. The moment they received the setback, the controls actually showed increased brain signal in this area, whereas the opioid users' brain signal in that area went down. So the conclusions are opioid users showed decreased persistence behavior in a task where the adaptive response to negative events is to persist, which has implication in their recovery. Emotional response to setbacks was decreased in putamen in opioid users compared to controls. So what are the implications for this study? I think this study's results have implication for utilizing a behavioral intervention to increase emotional regulation, as well as behavioral and pharmacological intervention to renormalize reward processing in drug queue processing network. One particular behavioral intervention I'm very interested is called mindfulness meditation, which has shown to improve emotional regulation, stress, and improves brain functioning. So in my current projects, I have 2 projects right now. We are examining the effectiveness of mindfulness-based stress reduction intervention on the mental health and drug use outcomes in individuals with substance use disorders. In another study right now, I'm examining the efficacy of a mindfulness-oriented recovery enhancement intervention on brain response, emotional regulation, and stress in women with opioid use disorders. And in the third project, I am using combined EEG and non-invasive brain stimulation to examine and improve cognitive control functioning in opioid use disorder. So I finally want to acknowledge my collaborators, my research assistant, my funding agency. Thank you very much.
Thank you so much, Dr. Ray, for that insightful presentation. It was very interesting. We'll now turn to Dr. Petros Livonis, who will be talking to us about pharmacologic treatment for opioid use disorder. Dr. Livonis, I invite you to share your screen. And like with Dr. Ray, I will give you 3-minute and 1-minute warnings. Thank you.
All right, thank you very much. And I see Mita ended 3 minutes early, so I have a few extra minutes there. Thank you, Mita, very much.
You're welcome.
So we're in good shape here. First of all, I want to thank both parties, the Democritus University of Thrace and Rutgers, for inviting me to this presentation today. I'm delighted also that it's in English and not in Greek. Μιλάω αρκετά καλά ελληνικά και μπορώ να σας ευχαριστήσω και στα ελληνικά για την πρόσκληση, αλλά όταν μιλάμε έτσι πιο πολύ επιστημονικά πράγματα, καλύτερα να το γυρίσουμε στα αγγλικά. And all that just meant English is better for me than Greek, especially when it comes to more scientific topics. So let me share some slides, and let me just see here one moment. We'll have it here, and here it is. Okay. So the topic is the pharmacological treatments for opioid use disorder, and I have no financial disclosures. The way that I propose we do that is spend just a moment on the opioid epidemic in the U.S. Mita did a wonderful job outlining that part already in the introduction of her talk. And then just say a few more specific things about the 3 FDA-approved medications that we have for opioid use disorders, methadone, naltrexone, and buprenorphine, before we conclude. Before we start, I just want to say that in 2022, the treatment of all of addiction, the substance use disorders, the behavioral addictions, the technological addictions that we spend a lot of time discussing these days, continues to be primarily psychosocial in nature. Individual psychotherapy, group psychotherapy, motivational interviewing, mindfulness, CBT, these are really the things that make people better. This being said, there are really only 2 addictions for which we've done well in finding medications to combat the illness. And these are only tobacco and opioids. Yes, we do have some medications for alcohol use disorders, and they're okay, and they can be helpful as adjuncts to whatever we do. But when it really comes down, the pharmacotherapy of addiction boils down to tobacco and opioids. But for those 2 addictions, we've done extremely well. I mean, the medications that we have are just so good. They can carry the burden of illness on their shoulder. And it's a mistake not to recommend them to our patients, or to at least have a discussion about medications for our patients who suffer from tobacco use disorders or opioid use disorders. All right. So with that, let's just go to some of the specifics. Let's start with the opioid epidemic. This is the same slide, very similar slide to the one that Mita presented a few minutes ago. But it just outlines the 3 phases of the opioid epidemic. We started in the late parts of the 20th century with the prescription opioid epidemic that really OxyContin and other full agonist opioids took over the United States and then gradually the world. And then something happened around 2010. And if you see the prescription opioids, this is the light blue line here, somewhat plateaus. I was part of these efforts. We changed the formulation of the pills. We put together the PMPs, the physician monitoring programs. And I don't regret that. I think we did the right thing. But it was a little too late. We got all these people addicted to prescription opioids, and then we made these prescription opioids less available to them. What are people going to do? Heroin. Heroin is cheap. Heroin is easily available. Heroin is now very pure to the point that injectable heroin is almost as effective as intranasal heroin. So, and that's an important piece here. Ever since the HIV, the AIDS epidemic, people have polarized what's good and what's bad, both in terms of sex and in terms of drugs. So for sex, oral sex became okay. As you very well know, oral sex in high schools is probably at the same level as kissing. And on the other hand, intercourse got vilified and thought that it was really, really dangerous. Again, coming straight out of the HIV epidemic. That translated into the drug world as intravenous use being particularly dangerous and frowned upon, especially by young people. But on the other hand, pills and anything that you can put up your nose is perfectly fine. And in that context, they increased the purity of heroin somewhere around here in 2010, skyrocketed the mortality of deaths due to opioids in the US. And that's the dark blue line right here. And then we'll have the third phase of the epidemic coming in 2013 with the introduction of fentanyl. And that is where we live now, where we just see that the line keeps on going up and up and up in terms of its mortality. All right, and the final frontier here is the fentanyl analogs, carfentanil being one of the major ones. You see here the relative potency between heroin, fentanyl, and carfentanil, and that's what we're battling in today. Some people may know that Rutgers has the toxicology center for the entire state of New Jersey, and 100% of the heroin samples that have come to our campus advertised as heroin also contain at least some fentanyl, and some of the fentanyl and or some of the fentanyl analogs like carfentanil. All right, for the highly obsessive ones of you, you must have seen here that carfentanil is spelled with an I, where fentanyl is spelled with a Y. It's not a typo, it's one of those quirky things of chemistry. That's the correct spelling of those two chemicals. All right, what do we do about it? As I mentioned before, pharmacotherapy. Pharmacotherapy is not an adjunct when it comes to opioid use disorders. Pharmacotherapy is the main fare. That's the thing that actually gets people better. Wonderful studies out of Yale have showed that if the patient is on buprenorphine, is somebody who suffers from an opioid use disorder is consistently on buprenorphine, whether you add cognitive behavioral therapy to the mix or not, will not really make that much of a difference. Wow, what a striking finding. We have been screaming from the rooftops that the combination of medication with psychotherapy and psychosocial supports tends to give us the best results, and yet we have pretty good evidence that, at least when it comes to opioid use disorders, the medication is the primary component. Of course, having some psychotherapy can only help, but it is almost criminal not to recommend a medication to somebody who suffers from an opioid use disorder. All right, so what do we have? We have three options here. Traditionally, pharmacotherapy of addiction across the board, not only opioids, has been following two major avenues. An avenue of an agonist treatment. Let me give you a molecule that's going to mimic the drug of abuse that you are so accustomed to out there, and fully activate the receptors to the point that the cravings come down. An example of that, of course, would be methadone. Or the opposite strategy, let me give you an antagonist, something that's going to block your receptors. So you try to shoot up. After a while, this is too much money, too much trouble, too much legal exposure, and you want to give it up. Classic example would be naltrexone for opioid use disorders. The amazing innovation over the past few years has been the introduction of a third avenue, of a third strategy, and that is the partial agonists. In the case of opioid use disorders, buprenorphine. Does a little bit of both, or actually a lot of both. It gives you a shield, it blocks the receptors, so you cannot really get high when you are using, but at the same time, it activates the cell at the 40% level, cutting down the cravings for opioids. A wonderful intervention, and probably the most important part of it, as you see in this diagram, is that even at very high doses, buprenorphine has only 40% activation of the cell, which means that even at very high doses, you do not run the risk of respiratory depression, coma, and death, something that you certainly run the risk with methadone. It has to be extraordinary circumstances, a combination of benzodiazepines and opioids and perhaps alcohol in order to end up dying of a buprenorphine overdose, and a special kind of buprenorphine as well. It's really very, very difficult to kill yourself on buprenorphine. All right, let's say a few specific things about each one of them. Starting with methadone, a full agonist to the mu-opioid receptor, highly reinforcing. As my friend Ed Salsitz often says, methadone does not have a sense of humor, so you need to know what you're doing, and dosing of methadone can be very tricky. There's a granularity in the dosing. 120 milligrams of methadone may make the patient safe, and 115 milligrams of methadone a day may actually get her or him in trouble. So, and on the other side, you have a patient who comes into your office and says that I missed my dose this morning from my clinic, and you give them another dose of methadone. Meanwhile, the patient might have already taken a dose of methadone and just wanted to get a little something extra, and then you may have a situation in your hands in terms of respiratory depression, coma, and death. All right, who's methadone best for? So, pain. Methadone has significant analgesic properties, and so if your patient does suffer from a bona fide pain syndrome, then you may want to address two issues with one medication. If you're going to be giving methadone for a combination addiction treatment and pain treatment, you need to give it in divided doses, 3-4 times a day. Nobody really knows why, but methadone for addiction is once a day. Methadone for pain is 3 to 4 times a day. The other thing is, at least in the United States, you can only get methadone in a methadone clinic, what is now called an opioid treatment program. And patients sometimes respond to this highly structured environment of the clinic. And this is another advantage of methadone. Some of the specifics have to be careful with QT interval prolongation and overdose, as I mentioned before, especially at high doses of methadone. Sedation, nausea, constipation, sexual side effects, major concern, especially for younger people. And of course, the drug-drug interactions, the synergistic effect with other central nervous system depressants like alcohol and benzodiazepines and other opioids. The majority of deaths from opioid overdose that you may be seeing in the news, this celebrity died of an opioid overdose, or that celebrity died of an opioid overdose, usually is from a combination of CNS depressant, and quite frequently methadone is one of them. This is street methadone. This is people who just buy it off the streets and they just use it that way. The majority of patients who get methadone in a controlled fashion from a medical establishment tend to do quite well. Okay, moving on to the other extreme, the issue of naltrexone. Naltrexone is a full antagonist to the mu-opioid receptor. It is absolutely not reinforcing. There is zero addictive potential to naltrexone. A patient once said, Doc, I will not steal, cheat, or lie to get naltrexone. There's nothing really in it for the person who suffers from an opioid use disorder. Fully blocks the receptor and keeps the patient safe. Downside, of course, is that it does not activate the receptor in any way, so it does not directly cut down the cravings, more through the path of disappointment in not being able to get high. Just a footnote here, naltrexone is a very similar molecule to naloxone. They're not exactly the same. We give naloxone in the hyperacute setting to reverse an overdose, and it's very, very effective in doing that. And naltrexone we give to patients to keep them safe in the long run. So naltrexone is the thing that we do for acute intoxication and overdose. Naltrexone is what we give for the treatment of opioid use disorder. Okay, what's naltrexone best for? Well, it may not be quite as effective as buprenorphine, but there are some patients who absolutely insist that do not want any opioid agonism sensation. Okay, let's stop here for a second. The majority of patients would love to turn a new leaf and never have to take any medication again in their life, and to just kind of not take buprenorphine, not take naltrexone, not take methadone, not take anything. But so many studies have shown that if you do that, then first of all, there's a very good chance you're going to relapse pretty much right away. And even worse, even if you don't relapse right away, you're going to be depriving the patient from the tolerance that they have to opioids, and therefore a little slip later down the line is going to be fatal to them. Let me say that again here. What we're saying here is that if you have a patient come in and you just detoxify them from their opioids, something that's quite common actually in Greece, where you just comes in and we give them something and they get over their acute withdrawal, and then we send them out without any pharmacological support, not only the patient is at a very high risk of relapse, but also will have decreased their tolerance to opioids. So if they're going to use the same dose that they are just so accustomed to before coming to you for detox, that dose now is lethal. Patient was used to 8 bags a day of heroin, stops using, hasn't used for 3-4 weeks, takes 8 bags of heroin again, boom, they're dead. And that, I mean, it's one of the most heartbreaking parts of my work, is that we end up losing patients exactly at the time when they're doing well. They've white-knuckled it, they are trying the best to stay clean, and then boom, they have a little bit of a slip, and that reduction in their tolerance is now lethal. All right, back to naltrexone. Naltrexone is best for people who do not want any kind of opioid sensation. So for these patients who insist, no, I don't want to have ever that kind of feeling of opioids again, naltrexone may be the best medication to give. Also, it has been shown that in correctional settings, jails and prisons and the like, they have been quite successful.
3 minutes remaining.
3 minutes? I thought I got meat as 3 minutes, so I have 6. All right.
Okay.
Okay, all right, thanks, Riva. So it has an oral form, 50 milligrams a day, and it has some liver toxicity that you have to follow liver function tests. And of course, you cannot give it with full agonists or partial agonists because of the drug-drug interactions. A much more popular way of giving naltrexone is 380 milligrams intramuscularly once a month. In terms of the molecule, is identical, so you have the same side effects and the same concerns as with oral naltrexone, plus the injection site. It's an injection in the gluteal muscle, so that's kind of a little bit of logistically difficult as well. All right, buprenorphine, everybody's favorite. There we go, partial agonist to the mu opioid receptor. Yes, it does have an addictive potential. Yes, it is reinforcing, but significantly less so than the full agonist, significantly less so than methadone. Who's buprenorphine best for? Pretty much everyone. It's our first line treatment for opioid use disorder. You have to have a good reason not to give buprenorphine in order to give somebody methadone or naltrexone. So it comes in a sublingual formulation. It's a film, you stick it underneath your tongue. It's very easy dosing, 8, 16, or 24 milligrams is what the majority of our patients are going to be taking. No QT prolongation. You do have similar side effects to full agonists, but less so. So you do see the sexual side effects, you do see the sedation, but much less so. And In terms of drug-drug interactions, again, the issue with opioids, with full agonist opioids. So you antagonize the full agonist opioid, and then you have to be careful if you ever need to have a combination of the two. All right, one of my favorite studies, a little older study, but what it showed here is the difference between buprenorphine detoxification versus buprenorphine maintenance. This is a year-long study, and as you see in the green dots, within a couple of months, pretty much everybody had dropped out of the study on the detoxification arm, while on the maintenance arm, about 80% of the patients still in treatment. Even worse, the percentage death was 20% on the detoxification arm, while on the maintenance side, nobody died. So, no detoxification, just do not detoxify people, put people on maintenance. This study has been duplicated since then many times. This is one of the best done studies with the taper condition, again at Yale, the David Filene group, who did it as well as possible with tons of supports, and yet the taper condition did much, much worse than the maintenance condition. All right, and so with that, I'm gonna make Riva happy. I'm done within my time limit. And just a couple of things to remember from this, that in 2022, buprenorphine maintenance is the first-line treatment for opioid use disorders. And the second one, which we didn't talk much about, but I would like you to think of, is that it's another medical illness. You assess, you diagnose, you treat. Addiction is addiction, especially when it comes to opioids. Things are very straightforward. It's a shame to treat diabetes and hypertension and depression and schizophrenia and not treat opioid use disorder, especially since we have such good interventions for it. And with that, I want to thank you very much. And I think we have a minute for questions, but if you want to wait until 1:10, that's fine too.
Petros, we're actually going to give you the 3 minutes, you see? Anyway, I think we're going to listen to our third speaker, and then I'm going to turn it over to Dr. Hatzaki. We'll hear our third speaker, and then if people have burning questions, they can ask the three of you them, and then we'll continue with questions afterwards.
Great.
If that works for everybody, for that way speakers' questions can be asked to the three of you. Okay, so I'm going to turn it over now to Dr. Hatzaki.
So my turn to introduce myself, to thank the organizers for inviting me for this, for chairing this excellent organization tonight. Excellent presentations, excellent organization, congratulations, and excellent opportunity for Democritus University of Thrace to increase international visibility, increase networking, having the chance for knowledge transfer, for expertise transfer. We should seize it. My task here is to introduce Elena Deligani. I met Elena recently and I'm impressed with her work. Elena is currently doing finishing her PhD at Aristotle University of Thessaloniki. She's working on the use of novel psychoactive substances of natural origin. She's a pharmacologist and she was graduated from the University of Hertfordshire in the United Kingdom. She has been an external research collaborator in the psychopharmacology, drug misuse, and novel psychoactive substance research unit of the University of Hertfordshire. Elena specializes in clinical research and translational medicine and epidemiology at Imperial College London and the Medical School of the National and the Kapodistan University of Athens. She is currently pursuing her PhD in clinical pharmacology and addiction, as I said, in association with the Hertfordshire, investigating novel psychoactive substance use, experience, and risk awareness. Elena, the floor is yours.
Many thanks, Professor Hatzaki, for the wonderful introduction. May I share my screen with you? Sorry. Is it okay? Yeah. Thank you. So hello, everyone. Many thanks for the kind invitation today. I'm truly delighted to participate in this wonderful initiative with insightful talks and opportunities to communicate science. I'm Elena Delitiani, and I'm currently pursuing my PhD in novel psychoactive substances, and I'm going to present you a part of our research, and I really hope you find this interesting. Just a small introduction about psychoactive and psychotropic substances. Psychoactive substances, when they are taken in or administered in one system, they're actually affecting how the brain works and other mental processes, such as, I need to make this, and affects how the brain works and other mental processes such as perception, consciousness, cognition, or behavior, mood, and emotions. Examples of psychoactive substances are alcohol, caffeine, nicotine, LSD, ketamine, cannabis, ecstasy, cocaine, and amphetamines. An introduction to novel psychoactive substances. The NPS term is the phenomenon of substances newly synthesized, produced with slight differences in their chemical structure to mimic psychoactive substances and actions of controlled illicit drugs and pharmaceutical products. The NPS term actually, some of you might already know and be familiarized with terms of farming or over-the-counter drugs abuse as well. Popular names for the novel psychoactive substances are designer synthetic drugs, research chemicals, bath salts, and legal highs. This is although a popular misleading term because it is actually due to serious health risks that they are concerning the novel psychoactive substances. Main sources of NPSs are via street, dealers, friends, acquaintances, head shops, or even web-based platforms such as darknet, social media, online drug markets. The novel psychoactive substances pose actually a potential threat to the public health. Over the last 2 decades, NPS's recreational use as a safer and legal alternatives of traditional illicit drugs may pose serious threat for public health and a challenge for drug policy makers worldwide. The term new does not actually refer to new inventions, but many NPSs were first synthesized decades ago, but recently became available in market. Use of NPSs has been strongly associated with the influence of friends in social settings, gatherings, festivals, and also spiritual religious events. Here you can see a table that shows the type of drug, the positive effects, and also the negative effects. One category of NPSs are stimulants that they actually mimic the action of cocaine, ecstasy, and amphetamines. Such examples are benzoferry, mephedrone, and legal speed. Positive effects are actually raising energy levels, rapid thoughts, euphoria, but also they have some severe negative effects such as paranoia, anxiety, confusion, psychosis, affecting cardiovascular, immune, and nervous system. Another category is about sedatives and depressants that they are actually mimicking benzodiazepines, and examples are meloman, having an opium effect, sex party pills, etizolam and pirazolam coming for benzodiazepines family. Their positive actions are actually similar to cannabis, euphoria, sedation, and reduced inhibition, although the negative effects are confusion, panic, dissociative effects, unconsciousness, coma, or even death, especially in cases of polydrug use and alcohol combination, anxiety, and also withdrawal syndrome. Psychedelics, hallucinogenic drugs is another category that they are having similar effects to LSD, ketamine. Such examples are salvia divinorum, space trips, methoxetamine, and bromo dragonfly. Positive effects are hallucinations, euphoria, warmth, and dissociation, although negative effects are confusion, anxiety, panic, altered perception, hallucinations, such as bad trips, and dissociative effects out of body experience. The last category is about synthetic cannabinoids, similar to cannabis, but even stronger. Examples are spice, synthetic marijuana, and the positive effects are feelings of being happy, euphoric, relaxation, drowsiness, hallucinations, mood and perception change. Negative effects are paranoia, such as panic attacks, psychotropic episodes, forgetfulness, nausea and mood swings, or sweating and loss of muscle coordination. Regarding one of the terms referred before, about ketamine abuse, the feeling of dissociation is actually like a black hole and feeling out-of-body experiences. Here you can see that the MPS's use is actually now a global phenomenon. So in 2020, it has been reported that NPSs have become available in more than 130 countries from all regions of the world. Also, there have been reported 1,025 synthetic MPSs, and you can see in this pie chart the examples of the categories in percentages, and the most of them are stimulants, then are synthetic cannabinoid receptor agonists, classic hallucinogens, opioids, and others. Regarding MPS side effects, the MPS side effects are really serious to concern. First of all, we are not aware exactly about the purity and composition of these products. Then MPS users are often polysubstance users, using alcohol, cannabis, and other substances in combination with MPSs. The MPSs may pose a high risk of acute harm and emergency medical treatment needed. These side effects of MPSs, some characteristic examples are seizures, aggression, acute psychosis, as well as potential development of dependence and withdrawal symptoms. NPS's users have frequently been hospitalized with some severe intoxications, even leading to death. Currently, 620 MPSs are monitored by European Monitoring Center for Drugs and Drugs Addiction. There are different regulations across different countries, of course, and UK is one of the biggest NPS consumers and introduced the Psychoactive Substances Act in 2016 in order to criminalize suppliers, but not actually the personal users. Here is about novel psychoactive substances, natural oils. You can see on the left a few examples of ayahuasca, salvia divinorum, magic mushrooms, kratom, cat, and mandrake. The MPSs are often derived and modified from constituents of natural origin. They are easily available to public because they are available in nature, and MPSs users are tending to sweeten the use in herbal natural MPSs. Their adverse effects, though, could be fatal if consumed improperly in recreational use. Some of them consumed as traditional medicines for many years or substances in religious spiritual events, but their abuse and addictive potentials are still not clear. So what are the motivations and settings of natural MPS use? And what about the health risk perception of natural MPS users? In order to answer some of these questions, we decided to conduct an international survey on novel psychoactive substances of natural origin. This survey was advertised on drug forums, social media, and university emails and platforms during 1st of July and 17th of November, 2018. The survey was ethically approved by the University of Rutgers. You can see here some of the main outcomes. The majority of responses were actually from the USA, UK, and Australia. Main motivation for natural MPS use was curiosity to experience something new and something different by 67% of the respondents, and there was a low, unknown, or not at all perception of health risks in the majority of the users, about 85% of them. The preferred natural MPS was magic mushrooms with psilocybin, 95%, and often combined, as was mentioned before about polydrug use, with cannabis, 63%. The correlation of natural MPS's use with lower level of education actually indicates the extreme need for enhanced education in schools, colleges, and generally in higher education and young populations. Many users, about 67%, they reported natural MPSs make them happier and more optimistic about their life. Sorry, can you hear me? Because I saw a problem with connection. Oh, all right, thank you. So many users, they reported natural MPSs make them happier and more optimistic, and they study their therapeutic potential in clinical settings. So clinicians should consider, in order to study them, in more appropriate therapeutical settings about what potentials could have. Regarding awareness of natural MPSs in Greece, we had 143 Greek respondents, 58% were female, and 64% were the age group of 18 to 25. The 44% was actually aware of natural MPSs, when the 76% believed that the natural MPSs use is actually acceptable. The majority, about 94%, had never tried natural MPSs in the past. Religion and life satisfaction affected significantly the level of natural MPS awareness, such as atheists and those that reported neither satisfaction or dissatisfaction or very dissatisfied with their life, they tended to be aware of natural MPSs. Also, the low level of natural MPSs awareness and health risks in Greek population should be truly considered about need for public education from experts and update of drug policies. Let's talk a bit about the impact of COVID-19 pandemic on MPS use, experience, and risk awareness. As you already know, COVID-19 pandemic and social distancing, they have a great effect on people's lifestyle. Anxiety, isolation, fear, and uncertainty, and economical issues, they actually cause many mental health issues and a mental health decline. Many people, in order to help themselves and cope with mental health issues, tend to use psychoactive substances, alcohol, and nicotine. The difficulties in medical support settings access as well, especially for vulnerable populations, such as patients with substance use disorders or mental health disorders, is another crucial thing to consider. So we decided to actually perform another international survey, online survey, between 8th of August 2020 and 3rd March 2021 in order to target the lockdown changes in most of the countries. The survey was advertised again in drug forums and social media, and also university emails, and it was ethically approved by the University of Hertfordshire. As you can see, the total respondents were 308, with 72 being MPS users. The majority of MPS users were from United States and Canada, 38%, and then from the United Kingdom. More than half of bisexual respondents and those identified as spiritualists or agnostics, they were also MPS users with a significant difference. Respondents with underlying health conditions vulnerable to COVID-19, they tended also to be more MPS users compared to respondents with no underlying health issues. Now, we need to consider some changes in MPS use during the pandemic. More than half of users, about 62%, changed MPS use during the pandemic. Some of them, they increased the use due to anxiety and they had more free time, about 28% of them. And some others, they actually decreased the use due to their own choice, 32%, maybe because they were also afraid because of the issues with COVID-19. The changes in settings of MPS use prior to the pandemic, the MPSs were used in outdoors, in nature, with other people, in social settings, about 47% of them, or in music festivals, raves, and again, social gatherings. Although during the pandemic, they actually tended to use MPSs alone at home with no any contacts, the majority of them, or with household members at home or outdoors in nature with others. But again, they preferred the isolation or being outdoors in case of seeing others. About the motivation and effects, the main motivations for MPS use prior to the pandemic was to experience something new and something different or get a good high. Although during the pandemic, they actually needed to cope with depression or anxiety, or even get happier and more optimistic about the life. Main effects after MPS use that were reported from the users were euphoria or mood enhancement, or even relaxation. And it is really important to state that the majority of emotions reported from the most of the users following the MPS use were satisfaction from 75% of them. Let's talk about the issue of polydrug use phenomenon. The polydrug use phenomenon actually can cause a greater risk of health complications. Similar trend on the users' most preferred MPSs prior and during COVID-19 were magic mushrooms, psilocybin, before and following the pandemic, nitrous oxide, and also entheogens from natural origin substances. The users, though, often combined their favorite MPSs with alcohol or even cannabis, causing the issue of polydrug use as mentioned before. Also, many users, they actually reported that during COVID-19, they had homegrown MPS sourcing, natural substances, and even stored supplies. Let's talk about mental health states and also life satisfaction in the USA versus Greece during COVID-19. You can notice on the two graphs that actually the changes and trends in both countries prior and during the pandemic were kind of similar, with much higher rates of life satisfaction before COVID-19 for both Greece and USA versus the high rates of actually dissatisfaction during the pandemic for both countries. Here you can also notice the health risk perception about alcohol and tobacco use in Greece versus United States. Regarding alcohol use, the half of Greek respondents reported no or low risk in alcohol use, when 20% they did not know, and a minority of approximately 30% stated a medium or high risk due to alcohol use, indicating a great need for further education in Greek population regarding alcohol safe use and also effects. In contrast, you can see with the red color that in the USA respondents, the majority, 61%, they stated a medium or high risk on alcohol use, when 30% reported no or low risk and 6% only that they did not know the health risks. This is actually showing to us a better level of health risk perception in the United States respondents compared to the Greek ones. Regarding tobacco use, you can see on the right that 28% of Greek respondents stated no or low risk on tobacco use, when 21% did not know the health risks. Only 20% reported high risk on tobacco use. In contrast, about the United States in red color, you can notice that only 8% of US respondents stated low or no risk regarding tobacco use, and 6% did not know, when more than half of the US respondents stated high risk about tobacco use. This is showing again that the United States respondents had a better level of health risk awareness regarding tobacco use compared to the Greek respondents. Finally, you can see here the health risk perception on NPS's use in Greece versus USA. The question that we had was if NPS's use is actually acceptable. You can see that more than half, about 53% of the United States respondents reported that the NPS's use is actually acceptable. Almost half of the Greek respondents, though, 43%, did not know if NPS's use is acceptable. Although the both categories of responses, they actually show a need for better education and drug policy updates in both countries, especially in higher educational institutions. Some conclusions here. The user's low perception about NPS's safety profile, especially during COVID-19 time and in COVID-19 vulnerable population, shows us that we should provide better education and information on NPS's health risks during this emerging time of the pandemic, because we actually face a pandemic during the pandemic. Many users during the pandemic found emotional healing and source of happiness in NPSs because they cope with boredom, anxiety, or depression. And we also need to consider, and the clinicians, to investigate further these therapeutic effects in mental health disorders. Finally, Greeks' low level of health risk perception regarding tobacco and alcohol use should actually lead to better education and implementation of prevention programs, especially in schools and higher education systems. Americans' belief that NPS use is actually acceptable shows that, again, we should provide further education from experts regarding NPS recreational use and other side effects. Here you can see a few references from this presentation. And I would like to thank you so much for your attention. If you have any questions, and of course, would like to express my deepest gratitude to all my professors, and foremost Professor Christos Kotogiorgis for supporting me all these years with knowledge and mentoring, and my two other institutions of Aristotle University and University of Hertfordshire, but also the Samaras Foundation for my PhD scholarship. Thank you so much for your time, and I hope you enjoy the rest of the conference. Thank you.
Thank you so
Very
much.
much, Eleni. Thank you for respecting time. We didn't need to give a warning. Diva, please.
Excellent. So thank you, everyone, both our session chairs and our presenters for introducing very different but definitely topics that feed into each other and interact in ways that give us a fuller picture of the situation in both the US and in Greece. We said we would go to hold questions until after our second session, which will begin in 8 minutes. So this is a time for a little break for anyone that needs it. But if our speakers are willing to entertain a couple questions right now, and there are questions from the audience, people, you should feel free to raise your hand and ask your question. Hopefully one of our presenters that is here would be happy to answer.
And you can, if you'd like, just post your question in the chat, either in Greek or in English.
I can take one question that's coming from the chat here about long-acting buprenorphine preparations. Yes, we do have the subcutaneous form that is good for a whole month, and we're very fond of it. It's just that there are still some logistical issues that have to be ironed out for us, and they have to do with the refrigeration of the product, of the particular pharmacy that has to be a specialty pharmacy to get the medication, reimbursement from insurance and things like that. But once we have ironed out all these logistical issues, I think that we're going to see a great benefit from the subcutaneous buprenorphine preparation.
Thank you, Pedro. Are there other questions on your minds right now that you'd like to raise with any of our presenters so far?
Petros, you mentioned earlier that a patient may come in saying, I missed my methadone, and then you give it to him and it causes a reaction and coma and eventual death. Mm-hmm. Is there a way to know?
Mm-hmm. Mm-hmm. Yeah. Patients who take methadone have a card. They carry with them always a methadone card. So you need to call. You need to call the methadone clinic and ask them about how much methadone the patient was given that morning. And even then, because you don't know if they've taken some extra methadone on the street and so on, you may opt to give a lower dose of methadone, maybe 20 milligrams, and then see the withdrawal symptoms. And if the pupils dilate, and if the patient has objective symptoms of withdrawal, then you can give another 5 milligrams of methadone. If the patient is in an inpatient setting, then it's a controlled environment. You can monitor the symptoms, and you can give methadone to address them. And even better, you can do an induction in buprenorphine, and when the patient eventually leaves the hospital, they are already inducted in buprenorphine and they can start the treatment.
Thank you.
Okay, so we'll keep monitoring the chat and looking for raised hands if you have questions, and we'll slowly begin to transition to our second session, which is a little bit shorter, and then we'll get to Q&A after that. And we have 2 colleagues and speakers that will be joining us, and I think I'm joined by Professor Christos Lepsaridis from Democritus.
Yeah, here am I.
Good morning. Well, good evening. Hi.
Good evening to all of you.
Excellent. Good to have you with us. So we're both here, and I think our speakers are here. Professor Dr. Nena is here on our screen, and I believe Professor Yanovitsky is en route to join us as well. Okay. So Christo, if I may ask you, when we begin at 12:30, if you would introduce Dr. Nena, and then we'll have her present, and then I will turn over and present. Sorry, it's Yanovitsky, and then we'll go from there.
So, Mr. Matthew, are we going to have a pause, or we just begin?
We said we would begin the second part at I think we said at 12:30, and so we can.
Okay, so we can start.
Yeah, so people can need a quick bio break or get water or coffee, refresh your coffee mug. Feel free to do so. And we'll begin in a couple of minutes.
Okay, so we are waiting for a couple of minutes. Okay.
So while we have a couple of minutes, and I have both Elena and Christo here on screen. Elena, you were talking about these differences in patterns you were seeing between the U.S. and Greece. Could you go in? Could you go in a little bit more depth into why you think those differences are there?
Yeah, definitely. So one of the differences that we found was especially about the awareness of health risk perception. Mm-hmm. So from the international surveys that we have done so far, we have seen that usually the United States and the United Kingdom, they're kind of more in front about the MPS's use. When in Greece still, we don't see that much trends. Although I would say that does not mean that in Greece we don't have MPS use, but actually there is a kind of underreporting, I would say. Mm-hmm. So our next step is actually to try with Professor Christos Kotogiorgis again and investigate further by developing Greek questionnaires, because the previous questionnaires were more in English because of my university in the UK. So we're going to try even more to target more Greek users by actually translating into Greek as well and making this more possible. Although it is kind of, I wouldn't expect, to be honest, that regarding alcohol use and tobacco use, we see again a greater trend in the United States about knowledge for risk perception, when in Greece it is really low. So that indicates that we really need to make more prevention programs regarding smoking and regarding alcohol use. So I would say that I wouldn't expect there would be such a great difference among Greek respondents in the United States regarding health risk perception about this too.
Yeah, that's a good point. I mean, my sense is from doing some field work in Greece in the past 2 or 3 years that there is a general, there's a need to grow the field in terms of developing public health and health communication campaigns around a variety of issues. And so that, maybe definitely one example of a project or a direction that could be pursued in this case as well.
And especially in higher education institutions, to be honest, this is kind of my vision, if I have this support and to be in a collaboration internationally, to make more targeted preventions in Greek universities and actually try to update some drug policies that they are not actually existed. And this is really sad. to be honest, because we need to move on to this. So we need to update these drug policies and make the students, the university students, more aware about this huge issue, because I'm aware that the MPS use and generally substances use is happening in Greece, but there is underreporting and is an issue that no one actually really focuses more in order to improve and make more things and preventions to tackle this issue.
Okay, so I'm just keeping track on time. So thanks, Elena, for the
Thank you.
response. It's just past 12:30 here, so 7:30 there in Greece. So why don't we begin our second session? For anyone that may have joined us a little later, I'll share the info with the schedule and people's bios and titles of their presentations. So Elena mentioned policy, so it's a good segue to the next session's focus. So we have two presenters from both of our institutions. And so I'm going to turn the mic over to Professor Christos Detsaridis, who will introduce himself, and of course our first speaker from Greece.
Thank you very much. I want to thank very much the organization committee for this honorary invitation to take part to this very, very interesting symposium. I'm professor at law school, so that means for me it's very, very interesting because it's I hear always new things about this aspect. I want to apologize. I thought it was my fault. I thought that the section was at 6:30, and I have to be 10 minutes past 8 to a law symposium. That's why I'm in the hotel to be here. I want to apologize about it. But Professor Matsagiannis, I think that you are here to find the solution of this small problem. So I think that it's time to hear the first speaker, Professor Nena Evangelia, who is going to speak about her aspect. So please, Nena Evangelia, you can start. We are with full careful about. Oh, I have some problem here.
Yes, I do.
Excuse me.
Sorry for that.
I have some problem. I see nothing. Oh, excuse me. That's a technical problem. So, oh, excuse me. Professor Nena Evangelia, you can start. I must solve my problem. Thank you very much, Professor Matsagiannis.
It seems that I must solve my problem too, but I think
don't know why.
I found the solution. Okay. Thank you very much. I would like also to thank the organizing committee for this honorable invitation to participate in the first joint symposium, and I'm looking forward for a second one. I would like to ask you to confirm if you can see my screen regularly, normally.
Okay.
Okay, so this is my disclosure statement, and this is what we are going to be talking about in the next 13 to 14 minutes. As the National Institute of Drug Abuse in the United States states, opioids are either naturally found in the opium poppy plant or are synthetic. Heroin is the most commonly used opioid, and it's not a medication, while prescription opioids refer to oxycodone, hydrocodone, codeine, and morphine. On the other hand, psychoactive substances refer to 4 groups of drugs: depressants, stimulants, opioids, and hallucinogens. As you can understand, this is a vast amount of information to share tonight. So I took the initiative based on Elena's presentation and the novelty of the subject and the time limitation to focus only to the new psychoactive substances at the second part of my presentation. We'll start with some background information. Heroin is the most commonly used illicit opioid in Europe, and the prevalence of high-risk use among adults, it is estimated at approximately 0.35% of the European Union population. However, as you can understand, there is considerable variability in the prevalence between countries because not all countries have recent data or not all countries use the same methodology, and therefore estimates need to be interpreted with caution. Although prevalence is low, opioids account for a disproportionately high amount of drug-related harm. This harm refers to high rates of dependence, often associated with unemployment, criminal acts, violence, homelessness, and social exclusion. It also involves a high risk of mortality, open drug scenes which affect negatively the quality of life in some communities, the risk of contracting infections such as AIDS or viral hepatitis. About epidemiology, these are the characteristics of opioid users in Europe. As you can see, we have a male predominance. The education is set at a secondary level mostly, followed by primary education. And regarding the occupational status, the larger proportion refers to unemployed individuals. As mentioned previously, heroin is the most commonly used opioid. And regarding route of administration, injection refers to 28% of users, while other routes like snorting or smoking to 72%. Excuse me. Greece is part of the southern branch of the Balkan route for opioids. It starts in Afghanistan and Pakistan, and it's heading northwest, passing through Greece. But fortunately, we're not very high at the rates of usage among adults, as you can see in the table. Another good thing is that a decreasing trend is observed since 2008 in our country regarding heroin use. Although, as we see from the sewage water analysis, heroin is the third most commonly found drug in sewage waters in the city of Athens, which is the capital of our country and the largest city. Almost half of the population in Greece lives in Athens. Regarding epidemiological facts in the United States, as you can see, there's also diversity between states and between counties in each state. In the left part of my screen, of your screen also, but I'm not an expert in this, so I will stay to some more striking details, like the fact that it was previously analyzed, the opioid epidemic. Actually, in 2017, the U.S. Department of Health and Human Services declared opioid use as a public health emergency. And what personally struck me most is the large amount of people who misuse prescription opioids. The number is over 10 million people, which is almost the entire population of Greece. Moving to policies, which is the subject of this presentation, this is the action framework for developing health and social responses to drug problems. This framework involves three basic steps. The first one is identification of the nature of the drug problems. The second one is the selection of potentially effective interventions. And the third one is in implementation, monitoring, and evaluation of the impact of these interventions. Based on this publication by the EMCDDA, this is the European Monitoring Center for Drugs and Drug Addictions, the basic priorities and policies, at least in the European context, and I think globally, as mentioned previously by Dr. Levounis, the core intervention is opioid agonist treatment, and for this, there are different available medication discussed previously. It is vital also to ensure the continuity of care and the high quality of treatment, and additional issues that are addressed, also that need to be addressed, is the treatment in residential settings. And another part is those users who are aging, and they need to be taken care of. We will discuss this later. Other priorities involve the access to opioid agonist treatments, which should remain a public health priority. Treatment services should be alert to the use of opioids other than heroin. Certainly heroin is the most commonly used opioid, but there are also other substances available. As well, the polysubstance use, like with alcohol and tobacco, should be always borne in mind. Improved monitoring is also required for novel and non-controlled synthetic opioids, which will be discussed at the second part of the presentation. The necessary steps that need to be taken are the following: pharmacological interventions, behavioral and psychosocial interventions, residential rehabilitation, self-help and mutual aid groups and well-being interventions, recovery, reintegration support services, and harm reduction services. Regarding treatment policies, effective long-term treatment of opioid dependence often requires multiple treatment episodes and combinations of responses, because relapse, concurrent mental and physical health issues, and social problems are common among those people. Therefore, the provision of drug treatment needs to be integrated with harm reduction programs, intervention addressing mental and physical health problems, and social support and rehabilitation services. Problematic use is also associated with social exclusion and disadvantage, both of which are significant social determinants of health, and you can understand the impact on the health of those populations. Additionally, long-term opioid users have a long history of injecting drug use, poor health, bad living conditions, and concurrent tobacco and alcohol use. All of these are factors that make them vulnerable to chronic health problems, such as cardiovascular disorders, liver disorders, and respiratory disorders. Regarding Greece, the Hellenic Ministry of Health has issued a policy document entitled Strategic Priorities on Responding to Substance Dependence, where the drug prevention was identified as one of the major priorities. Actually, drug prevention in Greece is implemented via a national network of 75 prevention centers, whose activities include the prevention of different kinds of dependency and the promotion of psychosocial health. This figure depicts the implementation of prevention interventions in school children in Greece in comparison to the European Union. As you can see, Greece, depicted with blue color, has in some parts differences with the European implementation scheme, which is depicted in red color, and in some parts results are the same regarding the implementation level. Regarding harm reduction policies, these include the provision of clean needles and syringes that unfortunately happens only in the cities of Athens and Thessaloniki, condoms, pregnant health education and informational material, and they train in safe use and first aid for all drug users. Vaccination against hepatitis A and B viruses are available free of charge. Results from a previous study in Athens suggested that access to treatment for chronic hepatitis C virus infection is low, but the results show that the access to HIV treatment has increased in recent years, probably indicating an increase in infection rates among opioid users. Regarding treatment policy, 9 out of 10 clients are treated in outpatient settings in Greece, and the majority who under treatment is due to their primary heroin use. Of course, the literature on policy issues in the United States is very rich, both at the federal level or at the state level. I chose to put 2 screenshots, one from the New Jersey state and the neighboring New York state, who I'm sure it's more interesting to you from who are watching today. And of course, CDC and other organizations have many publications on this stuff. Now, moving to the last part of my presentation, the new psychoactive substances. This term refers to a broad range of chemicals that are used or compounds that are used for the psychoactive properties, but are not controlled under the UN drug control conventions. They may be bought online, as Elena also mentioned, via social media or from high street suppliers. And in many times they are sold together with other better known substances. That means that consumers may not know what they are using. The characteristics of those users are the following. People who use drugs for recreational purposes, or marginalized groups like the homeless, or people who are regularly subjected to drug testing because those substances are harder to be detected and identified in routine urine testing. And also these new psychoactive substances are very popular within the prison population because it's easier for them to hide the substances. These substances are also linked to a range of harms to health. For example, poisonings, fatal or non-fatal, spread of drug-related infection diseases, and especially of bacterial origin. And it has been reported previously in a form of outbreak. And another issue is chemsex. It is the combination of high-risk drug use with high-risk sexual behavior, which can potentially result in hospitalizations, overdoses, sexually transmitted infections, and infections with HIV and hepatitis C. Currently, synthetic opioids and synthetic cannabinoids pose particular challenges to public health. The core interventions for new psychoactive substances include early warning system to monitor these new substances in the market, chemical identification of those new substances, training on new substances for health professionals, and creation of knowledge exchange platforms, and interventions based on previous experience, but adapted appropriately to meet the new needs. All national health authorities should be encouraged to develop guidelines for new psychoactive substances, including guidance on overdose management. Alternative, the previously published guidelines, like the NEPNO guidance, which was produced in the United Kingdom, may be translated and adapted to meet specific national needs. In conclusion, and this is my last slide, prevalence of opioid dependence among adults in Greece is low, showing a decreasing trend. Likewise, prevalence in Europe is low and varies considerably between countries. On the contrary, an opioid epidemic is observed in the United States, declared as a public health emergency in 2017. Misuse of prescription pain relievers is high in the United States also. The most common treatment approach is opioid agonist treatment, and the most effective, of course. Policies and proposed practices take into account the significant amount of harm associated with opioid use. And regarding new psychoactive substances, approaches should include adaptation of previously used policies, along with warning system and knowledge exchange. I would like to thank you all for your attention.
Thank you very much for this great speech. For me, it was very interesting, Professor Matthew Mazayanis, and I think that everyone has the same opinion. What I want to say before the specialist, Professor Mazayanis, speaks, is for me, and according to my science, is to find this special policy about the drugs generally, because the addicted persons need a special behavior from state, from the police. Otherwise, we have to send them to school, not to jail. Otherwise, we send them to the illegal market, and that's the problem. That means that it's not so easy if you want to find the best policy about drugs. You have to think about all the aspects about this problem. that means we have to cooperate with organization against drugs. Professor Evangelia Nena said about it. We have to cooperate with the universities, the government, the local governments, the municipalities, and as you know, it's very, very important how we behave with all these addicted people from the criminal aspect, because I think that's my opinion. We need a new reform about this. As we heard from Professor Evangelia Nena, the numbers are very strong. That's why we have to see again the drugs policy. I must say that according to the government, according to the Greek law, we have the last 20 years 6 or 7 new laws about it. But I think that the problem exists about the treatment, about the prevention, and I think that it's the big problem. It's the big question. Okay, thank you very much, Professor Evangelia Nena, and please, Professor Matsagiannis, I'm finished. Please.
Thank you, Professor Vatsalidis, for your follow-up on that engaging presentation. Thank you, Lila, if I may. I'm going to switch to take us back to this side of the Atlantic for a little while, and it's my pleasure to introduce you to my colleague, Professor Itzhak Yanovitsky, he's a professor of communication here at the School of Communication and Information at Rutgers. He's also the chair of the Health Communication Division of the International Communication Association, but also a member of the National Academies of Science, Engineering, and Medicine Standing Committee on Advancing Science Communication. He's an expert on areas of behavior change, public policy making, translational research, and program evaluation. His research in various contexts has focused on exploring effective mechanisms for improving the use of research evidence in policy and practice, as well as building capacity of communities to apply communication strategies and tools to promote population health and wellness. I think it's a great matching, perhaps, with our previous presentation. Itzhak has done a lot of work here in New Jersey across various communities that have been severely affected by the opioid crisis in the state and the country. So without further ado, Itzhak, the mic is yours.
Thank you, Matthew, and thank you for the introduction, and thank you all for inviting me. I'm really excited to be part of this initiative. Let me go ahead and share my screen if I can. So my goal is just to give you an overview of where we are with the opioid epidemic in the United States from a public health perspective, talk a little bit about the effect of COVID-19 and how COVID-19 impacted the opioid epidemic in the United States, which is a different trajectory, as you noted, compared to Europe and other places. And then talk a little bit about this kind of persisting challenges that I think we have in the United States, but we probably have in other parts of the world when we are trying to address this issue. So when we look at the opioid epidemic in the United States, and if you look at the kind of historical perspective, what you generally see from this graph is that we very much have an opioid problem in the United States. And that has been increasing over time, steadily, but we also identify 3 different waves with 3 different causal mechanisms that can explain that problem in the United States. So the first wave, again, beginning in 1999, has been mostly tied to prescription opioid abuse. So we talk about the fact that people had easy access to these very powerful drugs that were prescribed. People assume they're safe because they're prescribed. And we start seeing more and more people getting addicted to these drugs. And we all know the role of pharmaceuticals in pushing these drugs on the public and on the doctors who prescribe them. So we see that was the first part, and I want to point out that there was a response to that part that came down from different agencies. Part of that was focusing on education programs, trying to educate the public about that. Some other element focus on avoiding diversion, making sure that drugs that are prescribed legally are not end up in the wrong hands, and people are not using different doctors to get these drugs and therefore misuse them. There was also an element that focused on community capacity. So a lot of the work that I've been doing has been focusing on collecting these unneeded drugs from the community, so they're not stored in medicine cabinets and therefore people can access them who should not be getting access to these. And so there was also very big focus on curbing prescribing. So there was focus on reducing prescribing of opioids, and CDC came with guidelines, very clear guidelines at that point about how much opioid should be prescribed, under what circumstances, how we limited prescription of opioids, and so forth. What happened as a result was that there might be less prescription drugs available for abuse, but that means that demand shifted to another drug, which was heroin. So in the second wave, we're starting to see the rise in heroin use and heroin-related overdose. That's starting in 2010 and getting closer to 2013. And again, as you start doing things about opioids, we now have the third wave, which is based on, just in other parts of the world, on synthetic opioid overdose. So now we're moving into synthetic opioid, particularly fentanyl, which is more deadly. And as a result, we're seeing that kind of increase going on. So these are the three waves that are kind of distinct, and we can, again, identify them according to what the cause is. As we move forward, as we now look at data that's now emerging from the last 2 and 3 years, we start wondering about the effect of the pandemic on opioid abuse. And one thing I'll say right now that I'll repeat later is that in part because of the pandemic, we did not pay as much attention to opioids, maybe, because the focus of everybody was on COVID-19, and now we approach COVID-19, and that problem got intensified. The opioid problem got intensified as a result because of a few reasons I'll discuss in a minute. But just to give you a sense in terms of, again, epidemiological research studies, we find out, and you see these red lines here, this maroon color, showing what happened after COVID hit. And you can see in all indicators, there's been an increase in the problem among opioids. So you can see that even after we're experiencing some sort of decline, we were getting traction, we're doing something about that. There was a big jump right after COVID. And in fact, very recently, we passed this gruesome milestone of having, for the first time, more than 100,000 people dying from that. And so, again, that suggests to us that this is an issue. What we also know is that synthetic opioids are the primary driver of this increase. So, we're looking at a 38.4 increase in deaths that are associated, overdose deaths are associated with synthetic opioids, and then 26.5% that are caused by cocaine, which is more prevalent now. Now, again, as you look at the full map here, and this graph shows you what are people who are misusing opioids are generally using. You can see a vast majority, almost 98%, are still misusing prescription pain relievers. Among people who are age 12 and older, at least in 2020, 3.4%, which is 9.5 million people, just not a non-trivial number, misuse opioids in the past year. And then you see that the percentage is much higher, was increasing among the 18 to 25-year-olds, and then also from the 26 to older, and to a smaller extent, but still significant, for the 12 to 17. So across all age groups, we're seeing increase, particularly younger ages, we see this increase in opioid abuse. Now, so what are people abusing? And one of the things the trends that are particularly worrisome right now is that we notice that there's what we call polydrug use. So again, you're looking at people who are age 12 to older, about 4% of them are misusing CNS stimulants like cocaine, methamphetamines, and so forth. But it's much higher, again, among the younger age group. And what we're noticing here is that 18%, that's what I'm highlighting in the slide, 18% of people who are in that cycle misusing combination of 2 or more drugs. And so we see that kind of a polydrug use, which is presenting another challenge from a public health perspective. Now, again, when we look at the question of where is this problem concentrated, well, not surprisingly, it goes with generally what we call the social determinants of health. Now, what it is a little bit surprising in the United States is that opioid, particularly drug overdose and opioid use, has been mostly a white problem in terms of overrepresentation of white people in this group, but that has changed. Unfortunately, in recent years, again, mapping into this kind of disparities we see around COVID-19 with racial disparities and ethnic disparities. So you can see here that whereas, again, the percentage of people who die from drugs increased for all racial groups, there was a particular bump among African Americans. And so African Americans now account for disproportionate share of drug overdose, 17% compared to their 13%, which is their size within the population. So we see a very worrisome trend among Blacks and to some extent also among Latino, Hispanic population, even though there it's still a bit more even, but clearly we see the problem now diffusing. It's less of a problem among white people, but more among Blacks and Hispanics. So we want to be conscious of that. Another thing is where geographically the problem is. Okay, it used to be in the Northeast, in that area of the East Coast, and now it's moving into the West Coast. You can see there was a 98% increase in overdoses in this area, and that's consistent with data that showed there was a large increase in the availability of fentanyl in particular in these communities, and also aligned with data we have from drug tests to show that there was an increase there. So this is a real increase, and there's a real difference in terms of where the problem is now located. So what happened with the pandemic? So why is the pandemic described now in terms of a perfect storm that increase or contributed to the increase in opioid misuse and drug overdose? So one issue there was, of course, increased demand. Okay, to some extent, it's well documented now that increased trauma and social isolation, loss of economic opportunity, even boredom, all of these increase the demand for pain relievers. People were feeling pain, whether physical or emotional, and they were looking to relieve this pain with this opioid. So there was an increase in demand. At the same time, there was an increase in demand, there was a decrease in supply. Okay, because there was disruption to the drug supply because of the pandemic, things were closed down. And the market was at the same time flooded with counterfeit pills. Many of them are laced or contaminated with fentanyl. So people were thinking they're taking opioids that are legally prescribed, but in fact they weren't. They were counterfeits, and these turned out to be more deadly, obviously, than these other substances. There was also a decrease in the supply and reduced access to Nexalone, which is the drug that reverses overdose, right? So again, it's supposed to be something that's available in communities, but there was a shortage at one point. Pfizer couldn't produce enough. So there was a shortage, which also resulted in the increase in price. So that makes it less affordable to communities to have Nexalone and use that effectively to do this. In addition to that, compounding this was also decreased access to treatment. Again, people are locked down. They cannot see their physicians. They cannot go to the clinics and get the methadones or the other things they need in order to support their medication-assisted treatment. So there were barriers to accessing treatment. So the data here shows that only 11% of people with opioid use disorder received any treatment, at least at the beginning of the pandemic. In addition to that, there was also barriers to accessing the medication-assisted treatment because pharmaceuticals or pharmacies refused to dispose this under the current law. So the regulations that allow them to do that in a straightforward way. And so we had really hard time accessing the medications they need to deal with their opioid use disorder. Last thing, and I mentioned at the beginning, when all the attention of public health and the public and everyone is focused on the pandemic, that means there's less attention to opioid as a problem. So it just gets off the radar, so to speak. And so, it just went on growing unchecked, and that's an issue. So what was the response? So the American Rescue Plan Act, which is, again, a response to COVID-19, did make some serious investment in building that response to the opioid problem. I think you heard probably most recently President Biden speaking about opioids in State of the Union he's addressed that, highlight that as a major issue that we need to take care of. And there's certainly very receptive policymakers who want to do something about it. They recognize it's a big problem. They want to do something about it. So they allocated the resources. Again, these resources are mostly designed or intended to be used to reduce financial barriers to treatment and allow more naloxone freely available so people can use this when they need it to save lives. It's also designed to remove this restriction on dispensing methadone because that is, again, creating a bottleneck in terms of being able to respond effectively to people who need this to be able to stay on their recovery path. And also, obviously, one of the things we got to do better, perhaps, with the pandemic was telemedicine, right? Being able to invest in this building that capacity in infrastructure that allow this kind of telemedicine services to continue when patients cannot physically see their physicians because of this restriction in terms of social isolation and so forth. Now, if we look at, there's some basic evidence coming now to look at assessing the impact of this. And so there is evidence to show that Medicaid expansion under the Affordable Care Act was associated with an increase in the use of naloxone prescribing. So we, it seems to be moving in the right direction here. In terms of take-home dosing of methadone, that's also been increased in some positive effect on increasing treatment and engagement and keeping people away from being hospitalized. But there's some research that show that providing patients with more, a greater dose, so a greater supply of these drugs can potentially lead to misuse, but the evidence about that is mixed. So we don't know yet if there's a negative unintended effect, but there's clearly some benefits to doing that. So I want to get to the public health challenges. So now that we still in the midst of the pandemic, okay, hopefully maybe getting beyond the hard part of that, but it is expose a lot of the issues that we have in public health in terms of addressing this moving forward. And so one challenge that I think is obvious is that the opioid problem is very much a moving target. As I showed in my first slide, we started with the problem being primarily due to prescription opioid abuse, but then we shifted to heroin. Now we're shifting to synthetic opioids, and we're seeing that poly drugs. And so we keep chasing the ambulances here in terms of this epidemic keep reinventing itself. And part of the issue is we're not addressing the root causes. Okay, there's root causes that we know a lot about, but we have not been doing a good job in terms of public health, in part because it's attached to policy and some other things to do this. So the best we can do is to be prepared for the next evolution of that and be able to adapt or pivot our interventions accordingly. So we need to be more agile in terms of our ability to respond when a new kind of variation of this, just like we do with the variations of, or the variants of the coronavirus. Another issue I think here is that, and I think it came out also in the presentation before, it's very difficult to make public health decisions when you don't have full data. So, we have tracking systems that track prescriptions and track overdose deaths and so forth, but every state in the union is collecting different kind of data, not complete data. There's not central system. And so it's very difficult both to folks in, let's say, New Jersey, but also nationally to make any kind of decisions about public health when we don't have the data. And that's something we should have. We need to have a robust data infrastructure that provide ideally almost in real time information about what is the problem, what's going on in communities, how many people are showing up, how many people need treatment and so forth, so we can coordinate these efforts and do a better job. Another big one, of course, in the United States particularly is both that stigma and policies get in the way of sound policy. So, we mentioned before in the commentary that criminalization of drugs, drug use is not a good solution to things. It's very easy to criminalize the people who use or abuse drugs, but that end up putting them in jail where they have a much bigger problem than they had before. So we need to be able to think about policy, change the way we think about policy, move away from that focus on criminalizing and locking people down, moving more into this idea of prevention, treatment, and recovery. And that's where the money should be invested from policy perspective. That is also going to help remove the stigma that is very much attached still to opioid abuse in this country. Sorry. Another issue that, from public health perspective, that's an issue that exists all the time, is that fatigue, public fatigue is real. People are tired. People are tired to hear about COVID. They're tired to hear about opioids. And as they get more tired, they get more complacent, and they get less interested in doing something about that. So it's really important to keep providing this information. So yes, the pandemic is going on, and so we have two pandemics going at the same time. So it's really important that we give enough attention, both as a community, but also from generally the public, to the issue of opioid, because it's very tempting to believe the opioid problem went away. We had the same problem with HIV/AIDS in the 90s. When we start covering HIV/AIDS in the news, people assume the problem went away. It's still very much here, and then we need to make sure that we stay focused on that. Moving forward, one of the challenges, I just talked about two challenges, right? We talked about the pandemic and opioid, and now we have another big epidemic in the United States, which is mental health. And so you kind of heard about that. Again, State of the Union, the Surgeon General recently came up with really big concerns about that. So what I'm showing you here is, if you look at the left side panels, is I show you that, again, in part because of COVID-19, there was an increase in the incidence of major depression and general mental health issues within all age groups, okay, within the United States, particularly among young people. The middle panel here shows you that there was a clear association between the pandemic and the mental state of many people in this country who may not had a major depression or a mental health issue before, but have it now. And it's particularly acute within young people. And then the third panel show you again, for every age group, there's now evidence that depression, that mental health also translate into substance use. So now we have a triple problem on our hand. We have a compounded problem of the pandemic, mental health, and opioid abuse. And that's something that's going to be very challenging for us, because you need to treat all of these at the same time, because otherwise it's just getting out of hand. So what are the actionable recommendations? Again, very much aligned with what the scientific community sees, and some sort of consensus that's emerging about what is the right thing to do and what are the right investment to do. Again, this notion of making it easy to prevent opioid overdose. So in the United States, there's still a kind of debate about this kind of overdose prevention sites where people can come in and supervise, have supervision, where they inject drugs and so forth, because we can give them help if they overdose in that situation. Again, there's a lot of moral debates around that, but generally there's a consensus that we need to have more of these, particularly in big cities where there can be access to that. We need to increase the access, make it more easy to access medication-assisted treatment. And one of the big impediments for that was that requirement to get prescription waivers. So physicians need to obtain these prescription waivers to prescribe opioid, and then not being able to do that. So rather than even, let's say, a nurse being able to prescribe that, that will increase immediately the impact that these treatments it can have on a large margin population. But while restricting who can prescribe and under what conditions they can prescribe, we're just actually, again, impeding any kind of progress. So relaxing this, which happened recently with CDC new guidelines, allows to reach more people with this potential treatment. Another, of course, discussion, which is very important, is how we integrate the prevention treatment of opioids into the routine medical care. Right now, anything with opioid is outside of the regular care. And we find, well, I think scientists are now increasingly pushing towards this notion that integration within care, not only by the way of opioid, but also of mental health, is going to be a really, really important way of moving forward and getting traction with these problems. And we also have a really shortage of people who can help with treatment and recovery. And so we need to invest in the workforce that can provide these services, because there's a good shortage here. Again, I talk about decriminalizing opioid misuse. It's really important to remove the stigma from that, but also make sure that we provide the treatment that people need and potentially may not be able to get when they're incarcerated. And then I think one of the things we learned from COVID-19, which is really important for public health in general, is that we need to improve system-wide coordination. and responsiveness. We cannot have people doing different things at different places. We need to coordinate the epidemiological research with surveillance and treatment data and evidence-based practices. We need to work together and improve coordination of the system as a whole to be able to respond effectively, particularly when the next wave of the epidemic comes in or some other challenges coming in. So I think that's kind of the ideas. I'm hoping that was really useful. You have my contact information here. I'm happy to take any questions you may have.
Thank you, Itzhak. I think that was a great way to wrap up our series of presentations. I know I have questions. I see.
Professor.
Professor,
before leaving, because as I told you, I have to be in a Congress near here. I want to correct with this opportunity a mistake. It comes from a technical reasons. And I have to present Nena Evangelia because everyone from this, from the participants have to know about it because they are asking who was she with this excellent speech. So
no, there's no problem, Professor.
So
Thank you.
let me tell you that Evangelia Nena is trained in occupational medicine. She's associate professor in our university, in Democritus University of Race at medical school. She's head of the laboratory of social medicine and sociology. I have to tell you also that she's an author of 97 publications. That's why we had this very interesting and very useful speech. Thank you very much. I have to do it because it was a technical mistake.
Thank you, Christo, for that.
Thank you very much. I have to leave because they called me to the Congress. It was my fault. I wish you the best for your symposium, and I say all of you to the speakers that the speeches was very, very interesting. Congratulations for this. Thank you very much.
Thank you, Christo. Okay, so we have time for questions. I know I have already a couple questions that came to mind as I heard our last couple of speakers and connecting sort of the dots back to what we heard earlier earlier this evening, if you are in Greece. But I wanted to make sure that, so if anybody has a question, please raise your hand and we'll make sure that you get the floor, or feel free to type into the chat. I do see a couple of comments.
I think all of our speakers from our first session are also here, so you can ask questions of all 5 of the speakers.
And actually, if our morning speakers have questions of our later in the day speakers and vice versa, please feel free to do that now too, because you're coming to the issue from very different points of view, and there may be questions that come up because of those intersections. And maybe I'll use my co-host privilege to ask maybe a question, maybe as people are formulating the questions in their minds, and to ask those. I guess one question that came to mind as I was listening to Itzhak earlier and to your presentation, Lila and Elena and Christos earlier, was that now looking at the disparities of the inequality, the differences rather between different ethno-racial groups in the US. So we have a sense of who is carrying a disproportionate burden of the effects of the opioid epidemic in the States. And I'm wondering if you have a sense of what kind of disparities emerge in the Greek case, because the population is quite different, but also Greece has gone through not only the pandemic crisis, but also a very long economic crisis before that. And so I'm wondering if there are significant disparities that we need to be aware of but that may look quite different compared to what we're seeing in the U.S. If you have any comments or data you'd like to share, I'd love to hear more from you.
Yes, there is a large homogeneity in people living in Greece. The vast majority are of Greek origin. We do not have a lot of people migrating here in the country, and the majority also is from the same ethnic origin. So we cannot see this disparity regarding ethnic races. Actually, people, what we see is that usually drug use, substance use is usually met in big metropolitan areas in the Athens, the capital of the country, and Thessaloniki and big cities, and not so common in rural areas. Usually those people are marginalized and they face different problems. I think the problems due to their lifestyle after their addiction are globally the same. But as far as I know, there are not so distinct differences between those people. Certainly, migrants are entering this group of this certain group, but not so. The differences are not so overt as in the U.S.
Thanks, Lila. Any other thoughts on this, perhaps? If not, we can certainly move on.
Matthew, can I follow up? Is there any difference by social class, or is that even throughout? Just curious.
Very interesting question, because actually there is not in the Greek population, there is not again an overt class distinction. Certainly there is an upper class, a middle class, and a lower, as we can say, class, but it's actually not so overt in general. These kinds of addictions are not so often in upper class, and this was depicted actually from the educational level. A good thing, a good way to distinct classes in Greece is the level of education. It is what is accepted in our country. 12 years of education, that means secondary education, is the minimum of accepted to go to a higher level. That goes also for Europe. So our population is mainly on the primary and secondary education, so it indicates a lower class in this ranking.
There is a question here posted in the chat. My question is on BUP long acting. Is that in our supply chain in Greece as well? What has been the prescribing experience with it, if so? And keen to hear how some OST providers on this call from the U.S. have embraced long acting BUP.
I guess this may be directed towards me. What's an OST?
Oh, sorry, apologies. This is Jens Mamelidzis from WHO, opiate substitution therapy. So apologies. But yeah, and the reason I'm asking is just because from the Ukraine experiences, we have methadone pills and buprenorphine, but we were about to start doing some implementation science on long-acting buprenorphine. This is, and I know obviously that's something that is starting to be being offered in the US, and I just wanted to know maybe the values and preferences of your clients, and also maybe as a provider, as a medical doctor, and those actually distributing, buprenorphine, their kind of dispensing practices, because obviously, and the majority of our people on opiate substitution therapy in Ukraine are on methadone overwhelmingly. And so just, I also then was thinking about Greece, because I don't really know about the kind of the breakdown between methadone and buprenorphine back in the motherland. So thank you very much, and fantastic talk, Dr. Levounis, as well, and to others. Thank you.
All right, if I can just address that part about the long-acting buprenorphine. There are two products that we're talking about. One of them is implants that go underneath the biceps right here. There are 4 rods that they are inserted surgically, and they last for 6 months. The molecule is a little different than buprenorphine. It's probufin, but it does the same job. Essentially, you stabilize the patient on buprenorphine, and then you insert the rods here, and then you have to extract them after 6 months. We were a site for the original studies of this product, and I thought that we were going to have problems recruiting patients. The first day that we opened the study, we had people waiting around the corner from our hospital to get and registered. So there was a lot of demand, at least on the study protocol, but somehow the product never really took off. It may be financial considerations. It may be, I'm not sure exactly what. The extraction of the rods was quite bloody because, of course, after 6 months, the rods made adhesions with the surrounding tissue, and it was pretty difficult. You had to yank them out really hard, and it was you know, we had the OBGYN doctors do it because, of course, they know a lot about contraception, implants, and the like. But anyway, so that has been set aside. And the new long-acting buprenorphine product has to do with a subcutaneous product. The commercial name here is Sublocade. And that we do use, and we have a few patients on Sublocade. The thing is that it's a subcutaneous preparation, and you insert it in the abdominal area. And the analogy there would be, of course, with diabetes. And most people would suggest that eventually you should have the patient do the injection themselves. But at this point, they're not allowed. It has to be given by a health professional. And as I mentioned before, the logistical rollout of the product has not been very impressive. But then again, just came out less than a year ago, and maybe it's too soon to tell. We have every faith. We think that it's going to be a wonderful idea to have a long-acting buprenorphine product that we can give to a patient and not have to worry about diversion. It's another issue. We do have patients who come in for treatment here, and they will check their urine, and the urine is negative for buprenorphine. So what are they doing with all the prescriptions that we give them for the film? So you don't have any issues like that with the subcutaneous injection of buprenorphine. So anyway, these are the things that we're working on now. Bottom line, good ideas, hopeful for the future, but not there yet.
Thank you very much, Petro, for that. I have a different kind of question, but I wanted to kind of expand a bit on that discussion around the impact of the pandemic on the opioid crisis in the U.S. and maybe also take the question and focus it more on Greece. And I wonder if any of our colleagues or professionals from Greece have a sense of the impact, the combined impact of the economic crisis and the pandemic on substance use in Greece. I know that when I started again doing some more systematically doing some field work in Greece in 2018, the crisis was still not over, and there was still evidence that there were substance use was on still high. It had other kind of effects on people that were the rates of people getting infected with HIV, et cetera, was still higher than it was before the economic crisis, et cetera. So I'm wondering if these two crises together are changing somehow what we know about the substance use in Greece right now, and has it changed the way that researchers, professionals, and maybe policymakers are trying to address these issues?
I can give a very quick answer for the US, but I do not know about Greece.
Mm-hmm.
Very quickly, in the US, the best studied substance is alcohol. And what we do see with alcohol is a two-way, a bimodal distribution. The people who suffer from the less severe form of the illness actually end up doing a little better during the pandemic. And the people who suffered from the more severe form of the illness ended up doing significantly worse. The way we understand that is that the people with the lighter forms of alcohol use and alcohol use disorder had less opportunities to go out to the bars and socialize and do all these kind of things that we do with alcohol, and therefore reduced their use, while people with the severe form of the illness felt the stress and the pain and the anxiety and the malaise and the unpredictability of the pandemic, and got even worse. They had a lot of relapse, we had worsening of the illness, we had increased use of alcohol. I don't think that we have studied it as well for opioids. We have seen an increase in overdose deaths from opioid use disorder, that's for sure, but we haven't really analyzed in terms of severity of illness.
No, that's very helpful. And yeah, it's not opioids, but it gives at least a hypothesis that can be empirically studied in other kind of cases as well.
There will be a time lapse for the publication of the official data. Maybe in 1 or 2 years we will have the reports. But I would like to comment something that I just read in chat by Dr. Hodges Mameladis about the mental health crisis, which is very important, and it has been worsened during the crisis. We have data stating that depression rates during the lockdowns have reached to 12% of the population. These are published recently. So all these mental health disorders and all this stress that is being suppressed on people will certainly lead some of them to seek for substances, and maybe probably substance use will increase. I don't know if this refers to opioids, but certainly to cannabis products, and alcohol, as Dr. Livonis just said, will certainly be higher in the next analysis.
Thank you, Lila.
I'm sorry, I just wanted to comment on that, Dr. Nena.
Yes, this is my last name, yes.
Indeed, just to follow up on that, I put in the chat, there was a WHO global report, kind of like looking at, it was a global survey on that issue. I just think obviously it's just, you all know, like the situation in so many of our countries, and including in Greece, like we've had also, given our health system, our hospitals, have been obviously slammed, and we're seeing case fatality rates higher in Greece than other European countries. It's a function of a number of issues, but obviously a big segment of our older population did not get vaccinated. So I just think, as always, like mental health can be so deprioritized in times of not a pandemic. So I think this is this is an area that, we really need to critically prioritize, finance appropriately. And when we're talking also about vulnerable populations, I come from the world of HIV, so I think about our key populations, which includes MSM and sex workers and prisoners. And so, they're already sort of often don't have the same level of access to all health services, and obviously, mental health services is part of that. So I know the Ministry of Health in Greece is trying to do, or has established with like the WHO country office, some initiative on mental health. This is not my area of work, but I just feel like that's, it always is not as prioritized as it should be. And obviously, I think the situation will get worse than it will get better in Greece and other countries, unfortunately. Thank you.
I totally agree with you. Yes.
Maddie, can I make a quick comment? I mean, I know we talk about mental health, but one thing we need to also remember is that when I showed that graph about how prescription medications are the one that is now heavily being used, we need to remember people were not able to get elective surgeries. Many of us have back pains and neck pains and knee pain just from sitting all day. And so that kind of chronic type of pain is now actually increasing because of the pandemic, because of the limitation there. And so it's not surprising some people turn to pain medication to deal with just pain they have. And so we want to be conscious about that. Again, just kind of a lot of lessons to learn about the foreseeable and unforeseeable effects of these types of pandemics, and how we can better prepare people, both in mental health, but just generally, how do you keep good health or maintain good health during a pandemic?
If I may add here, absolutely true, and I don't disagree at all either with the comments or the data. But I also have to say that I am very impressed with the resilience of people, despite this incredible stress that we all got subjected to, and the deaths. Several friends of ours, one of my best Greek friend here died of COVID, Katerina Hadjistili, who's done wonderful work with intellectual disabilities. Some of you may know her. She was one of the first people. And the incredible kind of losses that we suffered, and yet we've managed to somehow emerge from that, and with some people who are going to be certainly suffering from post-traumatic stress disorder, and with the rates of depression and anxiety going up. But same thing as the financial crisis. So in Greece 10, 15 years ago, I'm even more impressed that we didn't have even more suicides and even greater mental health problems than what we ended up having. On the second issue of prioritizing mental health, one of the problems that we're bracing ourselves here is that even if society and politicians and legislature and so on prioritize mental health, which in some cases they seem like they are willing to do and finance it accordingly, we're not sure that we have the workforce to respond to this increased demand for mental health services. We don't have enough psychiatrists, we don't have enough psychologists, we don't have enough counselors, we don't have enough social workers, and so we are stressed. We're spread pretty thin in terms of the requests that we get for mental health services.
Other comments or questions from our audience that may either follow-ups because that is going in a interesting conversation unfolding, or take us in a different direction if you want. That's also fine.
I think an interesting theme we've heard, particularly in this last hour, and I think Yitzhak and Petros, you really brought it up, was the status of the pandemics, and I say it in the plural, within the COVID-19 pandemic, and almost the interaction among them all and the impact of those.
I'm wondering if, maybe thinking about here Itzhak and Petros's talks, especially, and maybe there's some insight from this from Christos and Elena too, who were collecting data in Greece. I wonder, like, do you see what kind of examples of interventions or programs that happen at the more sort of local level to help address the opioid or the substance use issues that you're working on? I know, for example, Professor, I was thinking that you were saying earlier that we have these cases of patients that come in and they may have, they get another dose of methadone, and they don't survive because they had something, they had another dose earlier. I'm wondering if there's programs that help address those kinds of things at the community level or at the hospital level that follow up with patients after they've left, or things of that nature. And I wonder, and sort of at a maybe slightly higher level from Itzhak working in New Jersey, like, what are communities doing that are facing these? I mean, there's specific counties across New Jersey that have insane numbers of cases of people overdosing, and I'm wondering, are there examples of successful approaches in those contexts as well?
two things from us that made a huge difference. One is free naloxone. Free naloxone kits for everyone, for patients, for families, at the pharmacies, for policemen, for pretty much anyone. Just make naloxone kits available widely. Don't have any cost associated with, no insurance reimbursement, nothing. Just make it available. And also to families, just give the kids to the parents and say, if by any means your son or your daughter ends up overdosing, that's what you need to do. So that's one big one. And the other one was free phones. When the pandemic first hit, and even today, we give phones to our patients who cannot come in to the office here, and we can talk to them on the phone. And we're not talking about iPhones or anything really expensive. You have to see, I wish I had one right here. They look like they're coming out of, I don't know, the 1970s or something. There are these very awkward looking phones without screens or anything, but we can hear each other very well, and we can reload them, and we do. And we're staying in touch with our patients.
That's very interesting. Very interesting.
Yeah, no, I agree, and I think I'll add that in the context of recovery, we find peer support is very important, it's very effective. We just need to have more peers who come in, because again, they have this ability to build relationship with the person going recovery. They completely understand the process, and they're well positioned to help. And so we have very great success with peer recovery. I think the other one I want to encourage us to think about, and something we did in New Jersey, was we often assume, when we come from public health perspective, that we are here to help people when in fact they're helping themselves. And so one of the things we've done with a partnership with Drug-Free New Jersey is we went to each community in New Jersey, particularly those who've been hit hard, show communities, for example, hit hard by opioid, asking, what are you guys doing that works? So we call it positive deviance, right? Positive deviance are the people who do something different and navigate the challenge and found some sort of a way. So some communities create some sort of mobile teams, right, that can go and find the injecting drug users, for example, and replace their needles. So they convert the school bus into a mini clinic that goes. Other had some other possibly other programs. So the idea of that project was to collect these best practices that the community generated themselves and then spread it widely. And last thing I'll mention, because it's something that I and Matthew care about, is data, and particularly this whole idea of data absenteeism. That in the kind of sensing methods we use and research we use, we often do not pick up on the problem among minorities and people who are not well represented. And so we need different kind of methodologies to approach and find this information. And communities have a very important role in helping us connect with people we cannot reach or effectively reach, and collect this data so we can have a decision. New Jersey moving into having this opioid dashboard, and as a subsequently the COVID dashboard, was really helpful, because you can see in real time, depending on which community you are, what's going on in your community right now, almost in real time, and make some decisions on the ground as a result. So I think there's a lot of, I agree with Pat, was the resilience. It should be a theme. And we need to learn from people or communities and show resilience and see what they've done that we can try and scale up potentially.
That's great. Thank you. Thank you for that. Riva reminded me that what we wanted to share with you guys, with everyone here, is a short evaluation survey we wanted to do to get your feedback on the event. So I've posted that in the chat. So if you're still here and have 3 minutes to complete that would be great. And for those of you that might be interested in getting a certificate of participation in today's event, you'll get the info how to do that when you complete the anonymous evaluation form. So again, that is posted in the chat for anyone that has the 3 minutes to get a sense of your thoughts on the event today. Great, yeah, so great answers to that. I mean, very helpful and insightful comments there on that question. I wanted to ask one, please, if you have a question, please stop me and raise your hand and ask it. I wanted to go back to Mita's presentation earlier today, which was a great example of like science happening where that is sort of not really easily observed, visible to the broader public. And I wonder, Mita, like how do you get your findings out to a broader audience? Like how do you get some of those findings that have an impact on what public health folks do, what health communication professionals do in addressing substance use in populations that they care about? How do you get that info out to them so they can inform their research protocols, their intervention projects, etc.?
That's a good question, actually. So during the past 6-7 years, I have been collaborating with Integrity House, is one of the largest drug addiction treatment center. So I usually periodically go there and talk about my research findings and share that with their clinicians and their CEO and multiple people, those who are working with this particular population. And also in 2019, there was a New Jersey-wide opioid symposium. And there also I presented some of my imaging finding, and I proposed that a behavioral intervention such as a mindfulness can be an adjunct to this kind of treatment in addition to medication or other kind of psychosocial treatment we are offering. So I think that really helped. That started a lot of communication among the communities. And right now I am taking part in a grant funded by Healthcare Foundation of New Jersey. And in that grant, multiple community drug treatment centers are participating. So the part of the grant is to train the counselors, those who are actually treating the substance use disordered individuals. So they got trained in mindfulness. And now they implemented that mindfulness in their setups. So already the counselors, those who would got trained, now they are offering the intervention to their clients. So now they're, so multiple sites are doing this kind of intervention. And I think that's reaching in a larger community, specifically in the Newark community, this is going on. So I have future plans to extend this kind of grant through other sources so that we can, utilize the mechanistic finding in the laboratory to outside to general people. So one thing I wanted to mention here also, I'm pretty much interested in minority populations. So specifically the area I'm working on, there are a lot of African Americans, that's their background in those kind of areas. And I personally feel that specifically women from minority background, they do not have much access to a lot of treatments because of their responsibilities at home, and they have double stigma. First of all, they are minorities, and then some of them are mothers. So that puts them into a very disadvantaged situation. And that's the area I want to expand in the future. And in addition to the medication-assisted treatment we are talking about, a kind of intervention that I am currently using, the mindfulness, can be offered through a virtual platform. So for that, they don't need to take time off from their work, and it's easily available. And we talked about mental health problem in Greece and in the US. I think this is, I personally a big fan of mindfulness, and it helps me personally. So I feel like anybody can get benefited from it. So this is the avenue I want to pursue in the future. And I was also thinking maybe some kind of collaborative projects we can develop in the future between Greece and the United States. And we have to find the common ground. I feel the common ground came up was the mental health problem. And you add the substance addiction to it. So I know that I think I'm thinking too far, but NIH offers grants for international collaboration. So maybe we can think about something like that in the future that will help both of the countries to address some of these difficulties we are experiencing.
Thank you, Mida. I like how you're thinking. That was clearly where the next question was, well, how do we take this to what's the next step we might pursue as a subgroup of people that may be interested in working together across the ocean here on issues that might be equally interesting in both countries. So thanks for taking us that direction. I am aware of the time that we promise it will be done at 10 to 2 or 10 to 9 in Greece, which I know is quite rather late. Maybe not if you live in Greece and it's what today is a Thursday evening, so still maybe late for on a weeknight. But if there are there any other questions that you'd like to ask? Oh, Elena, go ahead.
Yeah. Could I make just a short addition from what was stated before from Dr. Ray as well? To be honest, I have noticed before graduating from my master's in the UK that some charity organizations, they have actually started working on online platforms in order to connect the experts, the scientists working on MPSs, on psychoactive substances, and the actual users. So I think that this would be a really interesting idea to try and develop this chance of creating maybe a platform collaborating between different countries and try to make this connection between the actual experts and the users. So to be able to be more approachable to them and actually guide them significantly through a more kind of direct way. Mm-hmm. So I would be totally interested to that, and thank you for sharing your idea, and just wanted to make this addition. Thank you.
Thank you.
Thank you, Elena. Okay, so we'll definitely follow up with everyone after this in the coming days, unless there's other burning questions or less burning questions that you want to raise.
I'd like to make a 10-second comment. It's very short.
Please do so.
Yes, currently in Greece, there's a big discussion about the reform of the public health system. Mm-hmm. In its current form, it is centralized and targeting through healthcare and not prevention, and it's not community oriented. Mm-hmm. I'm sure that the next steps will involve communities and all those we discussed previously, and certainly mental health and addictions will be a large part of this reform. So I think the timing is perfect to maybe start thinking something about it, taking into considerations the reforms that will be following here in Greece.
That's a very good point. Yeah, it's true that primary care in Greece and therefore preventive measures and interventions are not particularly well developed, and there's a lot of room for growth in that direction. And so, if your sense is that that's a direction that the reforms being pursued they're going in, then maybe there's great opportunities to do more things at that level, including from some of us here in this room.
That is more a wishful thinking. I'm not sure. Okay. I don't know what would be the future.
Well, maybe we can advocate for these kind of changes, and maybe that's our mission before we do anything else. Thank you, Itzik. Thank you, Petros. Thank you, Christos and Elena. Thank you, Lila. Thank you, Mita. Who have I missed?
I would like to thank also you, Matthew, for coordination of this, and especially Riva for all her work that she has done till now. I think that when we started to communicate to each other about 7 or 8 months ago, we couldn't believe that we could reach such a nice meeting, followed by so many people. I think that was a really nice meeting, very interesting, with many data, with many ideas that came up, possibly for potential collaborations in the future between the two universities. And I think that we made the first step for this tonight or today.
I would echo what you're saying, Christos, and I thank you. I thank Matthew, our colleagues from Rutgers and our colleagues from Democritus for an outstanding presentation, and the audience for sticking with us for the past 3 hours. It's been a pleasure and an honor, and hopefully the first of future ones.
And as Ria pointed out, we'll be posting the recording on our IAPP Greece Initiative website here at Rutgers, and it will be probably available on Democritus website as well in the coming days. So feel free to rewatch and follow up on ideas that came up in session. And if you don't follow up, we will. So take care, have a good evening, and thanks to all of you again.
Thank you very much all.
Thank you. Thank you all.
Thank you all.
Bye.
Take care now. Bye-bye.